Hello.
Hello, good evening, sir.
Good evening, Ji. Am I audible?
Yes, you're very much audible, sir.
Thank you, Farin, for joining us. And you can welcome everyone for to the third day of this ASRICon. And Farin and two other rapporteurs are there. So I request Dr. Farin, who is a consultant endocrine and breast surgeon at Manipal Hospital, Delhi, to take over the proceeding and start the session. Most of the audience candidates are connected to YouTube. And once they send a question, it comes to my email, and then I will inform. Otherwise, we can have a small discussion with the moderator. And for example, plastic surgery team is headed by Professor Ankur Bhatnakar, sir, and they have four speakers. We can start the proceedings if they are connected. Thank you.
Sure, sir. I think all of them are connected.
Yeah, all
Uh,
of them are connected. I think Professor Ankur Bhatnakar, sir, can give the introduction of the topic and the team, and then we can start. And you can introduce, you can say a few words about what we need to know about the flaps and graphs, and then we start.
yes, sir. So shall I start then?
Yes, start.
Okay.
Yes, Farin, you can start.
Okay. Good evening, everyone. Nice to see all our esteemed faculty from SGPJI. I welcome on board everyone here, esteemed Professor Ankur, sir, who's been there with us for a long time. Sir, I invite you for your talk on basic introduction and terminology in plastic surgery. I hope all the students and other faculties who are there with us today will be benefited by the same. Over to you, sir, and I think we can start.
Okay, thank you, Dr. Fareen, and thank you to the Rural Surgeons of India Association for having us on board. So this session about plastic surgery is about the basics in plastic surgery, and we have four speakers. I'll be starting with the introduction, followed by Dr. Anupma Singh, who is additional professor at SGPGI. We'll be talking about the vascular anatomy of the flaps and grafts. Then we'll have skin grafts by Dr. Niklesh, and Dr. Rajiv Bharti, assistant professor here, will be talking about the flaps, and then we'll have 5 minutes of question and answers. So I'll start sharing my screen. So can you see the screen?
Yes, sir, it's visible.
Okay. Right. So we'll start about the basics here. So this presentation is about the basics of skin graft and flap. So skin grafting and flap cover are the basic part of plastic and reconstructive surgery. And it is also something which every surgeon, every general surgeon should also have a slight knowledge about it. And some basics have to be known because these are some problems where you will face in your day-to-day life. So at the start, I would like to thank Association of Rural Surgeons of India and especially the secretary, Professor Sabaratnam, for having us here. So as you know, plastic and reconstructive surgery is a problem-solving specialty, right? So we don't have any specific region or an organ system. So our first role is to prevent any wound from happening, and a plastic surgeon, once that prevention part is gone, then we provide a rapid, efficient and efficacious wound healing. And generally the healing is done by primary or secondary intention. However, if such healing by primary and secondary intention is not possible,
Without me, that is it. Like they cannot. So I started that, and now I'm coming because I
Sabha
know
sir,
these
could you
things
mute?
will will happen.
Sabha
Today,
sir, could you
all
mute?
7, 8 see breast and 3, 4 are unmeted. Now, lot of patients are there. Like now, at least some 50, 50, 60. Yes,
Sabas sir,
minimum.
your mic
I
is
have
on.
like already I have told all to be sent in your name because तू उसमें उनका फिर आज उसको ठीक किया है. मैंने बोलते भैया भाई I have written Dr. Shaun Mishra. Why did you go to the other person? One person was saying I know them. See, like I told like see this is not the thing because then you have to change the concept. No, but then they said no sir you operated you like then I told because see actually आपका नाम पे लिख करके जाने में how can she take and see and write also in that paper? Yeah.
5 बजे लगा दिया 5:55.
Right. So we'll continue. So as we see that plastic surgery as a specialty has a supporting role in various wound management. So once that primary and secondary intention healing is not there, then we go on to grafts and flaps. So generally, what is the relevance for a general surgeon? So a lot of times we encounter these problems like bed sores, diabetic foots, burst abdomens, and this is the place where grafting and flap covers are important. So just some basics that skin, which is the largest organ in the body, and is composed of two layers, epidermis and dermis. So we'll have the detailed discussion on this and the various other speakers who will be coming next to me will be talking about these. So we know about the epidermis, which has the 5 layers. Then there is dermis composed of the capillary and the deep reticular layer. And skin grafting is basically the transfer of tissue from one area to the other area of the body without its blood supply or nerve supply. So in a skin graft, basically the tissue is transferred, but its blood supply is not carried to the other part. And that blood supply, that tissue takes up from the new place where it is transferred. So there are partial thickness and full thickness grafts. And there is various advantages we'll see in detail in the upcoming lectures in the full thickness graft. And so there are indications where do we put a graft. Again, when the primary and secondary intention wound healing is not there and an ulcer is well granulated, clean, then the skin graft is put. And the most common equipment used is the Humvee's skin knife. And we'll have a short video also to how to take a skin graft. Then we come to flaps. So flap basically means a bunch of tissue. So it comes from the Dutch word, and skin flap is a tissue in which the donor tissue with its blood supply is taken to the recipient area. So this has its own blood supply, and then it comes to the new area and it has its original blood supply which is there. So again, flaps are used to cover wider areas, especially when bone, tendon or cartilage are exposed. Here, plain skin grafts cannot survive and the flaps are required. So there are various classification of flaps which will be seen in the various lectures based on the blood supply, based on the site of the flaps as well. And types of flaps are there. So then there are local flaps, there are distal flaps coming from a distant area, and microvascular surgery, we are free flaps. So all those advantages, disadvantages, how the flaps are raised, some basics will be dealt. So thank you very much for your patient listening. Just the introduction. So it was just an introduction, and now I call upon our next speaker, Dr. Anupma Singh, to start with the basics of the vascular anatomy. Dr. Anupma Singh, please can start and share your screen.
Yes, good evening, everyone. I'm Dr. Anupma. I'll talk on vascular anatomy of flap. So am I audible?
Yes, you are audible.
Yes, ma'am. And the slides are also visible.
So my topic is the vascular anatomy of flaps and graft. So as Dr. Ankur said, flap and graft. What is flap and graft? The graft and flap is the surgical techniques that we plastic surgeons use to cover defects, which cannot be closed by primary or the secondary intentions. Flap, as he said, flap is vascularized tissue. It has its own supply and it is mobilized from its donor side to and transferred to the
Dr.
other.
Anupma, your slides are not moving. We are only seeing the first slide. I think you have to remove that presenter view and go to the screen view.
Okay.
You can stop sharing and then share again.
Purnima Charita, na?
Is it? Is it visible now? Hello?
Yeah,
Yes,
but there are some
it's
artifacts coming in
visible.
between.
Yeah, there are these gray areas which are coming in the
Lines are
slide.
coming in between. You can start now. I can start speaking now. The next slide is visible.
Okay. So the flap has its own vascularized tissues, so circulation, and it is mobilized from the donor side to the location where we have to cover the defect. And the skin graft, as he said, skin graft is removed surgically from one area and it is transplanted or attached to the other area.
Ma'am, you're not audible.
Hello?
Yes, yes,
Hello?
you're audible. Yeah, you're audible now.
The slides. So anything we fab, it has classification to work with in ease. So flap are also classified on the base of compositions, circulation, congruity, configurations, constructions, and conditioning. That is, which material is used, muscle, skin, fascia, or from where place it is taken, distant or regional, or it is any fabrication is done. These are things to decide how do we classify the flap. And this system is developed by the Cormack and Lombardi, and it provides comprehensive framework for describing and also categorizing flap for reconstructing surgery. So the blood circulation is one of the way to classify the flaps too. And this slide shows the circulation of skin and subcutaneous tissue. The main vessel supplies to the skin. It goes through either through the muscle or the septum. In skin, it is makes the plexus in below the dermis, that is subdermal plexus, suprafacial plexus, and subfacial plexus. These plexus are important when we raise the flap. So according to vascular supply, we classify the skin flap into random on axial, fasciocutaneous, musculocutaneous, or the free flap. So the random pattern flap, as it denotes the random, means the vascular supply is not particularly decided. A known vessel is not there. So it is based on the subdermal plexus, and its distal aspect of the flap remains vascularized to the small vessel running through the underneath the dermis, that is subdermal plexus. And because of this, the blood flow to the distal area is decreases. So the length of flap we can not increase to after a certain length. Another is axial pattern. In axial pattern, there is one defined circulation is there, that is design incorporates a name artery, and so it runs along the flap, And this perfusion, because of named vessel, the perfusion of the distal aspect of the flap is more defined, and it is so we can take a longer flap when we take the axial pattern flap. Fasciocutaneous flap, as we said, we include fascia along with the subcutaneous tissue. So we use skin, fat, and fascia without muscle. And this the importance of this is this flap is very pliable and it has a circulation. Either is supplied by the perforator fat plexus or the classified in the vascular entry. This can be classified as a vascular entry. So large vessel, single vessel, and or the pedicle type, perforator based or the pedicle type. So this is an example. What we have done, our abdominal flap, it's the pedicle flap, fasciocutaneous flap. Done is from the electric burn in this patient. So perfurosome. The perfurosome is defined as a territory perfused by the single perforator vessels or the named artery of the name artery. And it can supply either directly or through the muscle or the subcutaneous. Perforate, so we can raise on these perforator, the flap, it's known as perforator based flap. And the flap centered around a single blood vessel, that is perforator. And this perforator comes through the facial layer from underlying muscle or the muscular septum and supplies the subdermal plexus. And it can be classified as it supplies to the skin. The type 1 is indirect to the muscle, type 2 is indirect to the septum, and type 3 is direct to the skin. The vascular anatomy of muscle vascular anatomy is as described by Math and Nice, and is also classified it into type 1 to type 5. Type 1 in where the only the one major vessel is there, like tensofacial lata. In gracilis, it's type 2, where the one major vessel and two other 2 or 3 are the minor vessels. And type 3, where the two major supply on which we can raise a flap in either of them. And example is gluteus maximus. Type 4 in sartorius, there are multiple minor vessels, so we can't raise a whole of flap in a one vessel. So we raise flap on the short segmental way. And type 5 is latissimus dorsi is example. It has one major and 2-3 segmental. So we can raise flap both on one major and on the segmental too. Free flap, as it denotes, it's free from origin. The flap entirely detached from its donor side, and it is unlike local flap, it's partial, which is partially attached. It is reattached to the other side with microvascular techniques, with the tiny vessels on that area. It's we have taken radial for artery forearm free flap. So vessel is there, artery, radial artery, and this vein. And we have applied for the defect in the oral cavity for the lining and the cover. Angiosome. Angiosome is a concept given by the Taylor and Palmer. In the human body, there are 40 angiosomes, and it's described as the skin perfusion in 3D juxtapuzzle. So each artery originates from the source vessel, perfuses a skin territory along with the underlying structure. So angiosomes are not isolated entities, and they are related to each other by the connecting vessels, which is called the choke vessel. So this choke vessel is very important for us plastic surgeon, because when we raise the flap, sometimes circulation is not so good. So we do delay. So these two vessel in delayed flap opens up and gives extra circulation to that area. Now the skin graft, vascular supply to skin, as it's said, skin graft doesn't contain its own supply. So it needs to integrate with the recipient area. So there are two types of grafts, split thickness and the full thickness graft. The split thickness graft contains epidermis and part of dermis. And full thickness contains epidermis and along with the whole of dermis. So how the skin graft revascularize or take? So when we take skin graft, it's so it doesn't have its supply, so it takes from the recipient wound. First, when we attached it to the recipient side, it imbibe plasma. The nutrition come from the plasma, which is in between the graft and the recipient. So it's with the method of imbibation. And after that, the inoculation occur. Inoculation is what? Where is budding of the vesicular sites occurs to grow new vessel. After that, the new vessel develops and revascularization of the area occurs, and the new vessel goes into wound bed, from wound bed to the graft. And this is where we say when the vascularization is complete, the take of the graft is there. The success of the skin graft depends on the well-vascularized and healthy wound bed. It's a split thickness graft we've taken where it's fenestrated in child and it is non-fenestrated. Both are split thickness graft used for the cover of the defect. It's a full thickness graft we've taken up for the ectropion of the eye. So factors that compromise the vascular supply of skin graft is the recipient site is poorly vascularized, and there is increased chance of the graft failure. Along with if the infection is there, it also causes interference in the establishment of new blood supply. So with this, I'll conclude my slide. Thank you.
Thank you, ma'am, for the talk.
Thank you.
Can I invite the next speaker, Dr. Nikhilesh Kumar, Assistant Professor Plastic Surgery at SGPGI, Lucknow. So you will take over.
So, ma'am, am I audible?
Yes.
Yes, you're audible. You're audible.
Okay, ma'am. Okay. So my slides are audible.
No, I can't see your slides. You need to share them first.
Just give me a minute, ma'am.
Right.
Okay.
Yeah.
That's fine, ma'am.
But you need to put on the
Yeah.
full screen mode.
Okay, ma'am.
Down, right?
Yeah.
Just come down.
Okay, just give me a minute. Just give me a minute. Is this fine, ma'am?
Yeah. Yes. Yes.
So good evening, everyone. So my topic is skin graft, its various types, indications of skin graft, and various techniques. So I will be dealing with, as told by ma'am, about the split thickness skin graft and full thickness skin graft. My content will be a history, a brief history, skin and components, the definition and indications, the mechanism of graft take-up, the types of graft, harvesting instruments, the donor sites, graft preparation, the post-operative care, along with complication. So we have, so history dates back to tile maker castes in India. So what they do, they used to beat the skin of a pig or some animals with the help of a stick, so it becomes thin, and they used to do that, and they used to use that. So what we get from that is a concept of a thin skin graft. So the full thickness skin graft was first given by or Boronio in 1804. Sir Ashley Cooper grafted FTSG from the man amputated thumb to cover the stub. Riverdin introduced the pinch or epidermic graft. The Ollier and Tharge used the split thickness skin graft to cover the various defect. FTSG was also given by Wolf in 1875. So what is a skin graft? A skin graft is a tissue of epidermis and varying amount of dermis, and it detached from its own blood supply and given to a new area, and where it get its blood supply. So what is a graft and a flap? The graft does not maintain its original blood supply, while flap always maintain its original blood supply. As you can see in the pics. So as told by the Ankur Bhatnagar sir and Anupma ma'am, these are the epidermis, dermis. So we have a 5% of epidermis and 95% are comprised of dermis. So and followed by subcutaneous tissue and sweat glands. So epidermis is ectodermal in origin. There is no blood vessel, and it always relies on diffusion from the underlying tissue. Stratified squamous epithelium is mainly composed of keratinocytes, from which we got our color of skin, and it's separated from dermis by a basement membrane. So what is dermis? Dermis is mesodermal, contains collagen and elastin fiber along with ground substance and appendages. It is made up of two sublayers, as the superficial papillary and deep reticular. So what these two layers do? Epidermis provide the mechanic to provide a protective barrier against the mechanical damage, the microwave invasion, and it control the water loss. While dermis, it gives a mechanical strength, the sensation, touch, temperature, pressure, and it also thermoregulates our body. So the classification of skin graft is a autograft, which is a tissue transfer from one part of the body to the another. Another one is homograft or allograft, tissue transfer from the genetically different individual of the same species, means Homo sapiens to Homo sapiens. While the xenograft, a graft transfer from the individual of a species to another species, like from pig, from rat to humans. So there is another classification based on the depth and thickness, the split thickness and a full thickness. Split thickness contain 100% of epidermis and some part of the dermis. It can be classified further into thin, medium, or thick. The full thickness always contains 100% of epidermis along with dermis. So further, the thin, the medium, and thick. So it based on the thickness. The thin is 0.005 to 0.12 inches, from 0.12 to 0.18 medium thickness, and thick from 0.18 to 0.030. So full thickness skin graft composed of, as told by earlier, epidermis and entire dermis. So these are the difference of split thickness or full thickness. As thickness already been told, instrument required is Hummies and dermatome. We will talk in detail in later part. The donor areas are thigh, legs, upper arms, forearm for split thickness, and auricular area, clavicular area, and groin area. So the donor area always heal by epithelialization in split thickness, and primary, we have to do a primary closure for full thickness. Recipient area always takes easier for a split thickness, but not for full thickness. The graft contraction is more, secondary is more, while primary contraction occurs in full thickness. Color changes, there is always some problem of hyperpigmentation in split thickness, and it's not in full thickness. While the resistant to trauma due to its thinness of dermis, it's poorly tolerated by split thickness, while the full thickness have a better resistance. There is no hair growth in split thickness, while grows after a long time. The hair grows after a long time in full thickness. Another PPT showing the difference of STSG and FTSG. I'm not going in detail regarding this. So what are the donor sites for both the skin graft? The ideal donor site should be a skin that is identical to the surrounding skin of the recipient area, such as the blush zone of the face. So skin varies dramatically from one anatomic site to another anatomic site, though. So skin of the abdomen is quite different from the skin of the face, and it always varies by a age and a gender. So the donor site of STSG are thighs, as shown in a pic, upper arm, flexor aspect of the forearm, the plane surface of the torso, lower leg, and other aspect of the forearm. FTSG can be taken from the auricular area, the post-auricular area, upper eyelid, the supraclavicular region, the flexible skin, thigh and abdominal skin. So what are the techniques of graft harvesting? For split thickness, the donor area should be lubricated. The guard of the knife is usually set at 0.03 to 0.045 mm. The assistant should apply a continuous pressure to achieve an even surface. So instrument we need for STSG and FTSG are the dermatomes for STSG, freehand, the downs blade, another blade, Beck's blade, Humvee's knife, Brathwaite, Watson, silver knife. I will tell in detail later. The power assisted, electric, air zimmer, the drum assisted, the Reese and Patek hood. So these are the various Humvee's knife, the modifications of Humvee's knife, that is Brathwaite, Watson, and Cobbett. So these are the area of harvesting the split thickness skin graft, the medial aspect of the thigh, the lateral part, lateral aspect, the posterior aspect, and these are also the areas of for split thickness skin graft. So we can see in one hand the surgeons hold this harvested skin graft split thickness and the donor area showing salt and pepper appearance of the bleeding. This is a healed area. Now I am going to show one video of harvest of split thickness skin graft.
Correct. Now you need to have two very good assistants. Now talk through. So they will be applying pressure on both the sides so that this becomes absolutely taut, enabling the surgeon to just harvest the graft. As you can see, I am placing my Humvee's knife absolutely flat, parallel to the surface from which I am harvesting the graft, and in a to and fro motion. This is how the kind of graft is a medium thickness graft that we get. So high, you need to flex your leg, and again the same procedure. My padding under the thigh so that you get a flat surface. Now your assistant needs to press this tendon again so that you get a flat area. So the saline and now paraffin helps us to lubricate the area from which we will be harvesting the graft. Apply pressure on both sides to make it taut, and again to and fro motion. And this is how we mesh the graft. So we'll in this I'm making cuts parallel to the longitudinal axis of the graft, and as you see, each row of cuts is actually interlacing, interdigitating between the adjacent two rows. So this is how it is. This is the first cut. The second cut goes between the two cuts, and again the third row as similar as to the previous one. So this can help the graft to expand. Correct? Now,
So what about the full thickness skin graft? So donor sites are post-auricular skin as told earlier. So we have to have the template, especially for full thickness skin graft, and harvested graft should be 5% larger than the template. So we take a template, we take a defect, put a template over that, and the full thickness harvested full thickness skin graft should be 5% more than the or larger than the template. So we have to have prepare the skin graft. So we have two types of graft preparation: the meshing and pie crusting. Meshing is meshed. STSG is meshed to increase the surface area of the graft. It can be 1:1, 2:1, up to 9:1. But mostly routinely we do 1.5:1. But disadvantages are a cobblestone appearance and suboptimal cosmesis, and there is always a increased risk of contracture. Pie crusting is done in FTSG and we have to put some sutures in order to have a better control for the defect. So these are the post mastering skin graft, split thickness skin graft, as we can see in the pic. Another photograph showing the mashed skin graft, and as you can see, it can cover the lot and whole of the area of the defect. So what are the phases of graft take? So it includes three phases: the plasmatic imbibition, the vascular inosculation, and neovascularization. Plasmatic imbibition is from 0 to 48 hours, vascular inosculation from 48 to 72 hours, and neovascularization is from after 96 hours. So there will always be a initial graft ischemia. The ischemic phase is also known as plasmatic or serum imbibition. So initially the graft is nourished by a fluid from the wound bed, approximately 24 hours in proliferating wound and 48 hours in a wound. Due to fibrin, the graft adhere to the wound bed. Graft always absorbs serum, becomes edematous, and it gains approximately 40% of the initial weight in first 24 hours, and then it begin to lose weight after 96 hours. Metabolism become anaerobic, and pH of the skin graft falls to 6.8. Inosculation occurs after 48 hours. There is a microvascular growth of the capillary sized blood vessels from the wound bed and into the graft. The peak vessel density occur around POD 7, postoperative day 7, and begin to decrease by this. An acceptable vascular networks form in the fibrin layer, blood flow is established, and the skin graft become pink. There is now the revascularization. There is formation of new vascular channels, which is known as angiogenesis, which is anosmosis of the old and new vessels. The recipient-driven endothelial cells migrate to the graft and eventually replacing the graft endothelial structure. At 72 hours, sluggish blood flow appears within the graft. By the 10th of day, skin graft become fully vascularized. There is a role of MMP1 and MMP2 to initiate angiogenesis. Revascularization starts from the center of the graft. The postoperative care of the skin graft, we always begin with the non-adherent dressing for the skin graft, immobilization for proper graft adherence, circumferential wrap with a splintage, and it should be removed after 5 to 7 days. There is also a bolster dressing for the skin graft. The first dressing, the heavily colonized wound, 1 to 3 days, FTSG, face and hand, we can remove the first dressing after 5 to 10 days. The graft color changes from pale to pink around 3rd to 4th postoperative days. So dressing of the donor side we can do from the fine meshed gauze, the paraffin gauze, and over this we can put a semi-permeable polyurethane dressings along with silver-based absorptive dressings, and donor side usually heals within 7 to 21 days. Graft fixation adherence is crucial for graft survival. We usually do tie-over bolster dressing filled with betadine soaked cotton balls. For larger graft and in mobile area such as hand, axilla, we apply a negative pressure wound therapy, and we can apply a fibrin sealant, especially for STSG. We can also store skin graft if there is a lot of bleeding from the defect. So replacing the excess graft on the donor side, we can put for maximum for 5 days, and we can put a saline solution at 4 degrees Celsius, and we can put the skin graft or store skin graft for up to 3 weeks, although the viability decreases along with the time. So what happens after the skin graft? There is always a two types of contraction: the primary contraction and the secondary contraction. The primary contraction occurs immediately after harvesting a graft. This is due to dermal elastic recoil capacity. It is more in full thickness skin graft, while the secondary contraction is more in STSG, the split thickness skin graft, and it is due to myofibroblast. So what is the mechanism of skin graft healing? A healthy ungrafted wound bed will undergo healing by secondary intention, granulation, contraction, and reepithelialization. Skin graft incorporation in the wound bed occurs through process of graft take, which indicate graft healing and survival. So what happens after the skin graft? Sweating of the skin graft depends upon the number of transplanted sweat glands and the degree of sympathetic reinnervation. FTSG will always sweat like a recipient site. Sebaceous gland activity is mainly in a thicker graft, so it is more in the FTSG. Hair grows always in full thickness skin graft if well taken and with no complication, but doesn't occur in hair growth doesn't occur in split thickness skin graft. So what are the histology of the STSG and FTSG? So the epidermis always doubles in thickness during the first 4 days. Between 4 to 8 days, epidermis continue to proliferate and begin to discriminate. Cellular turnover increases for up to 4 weeks after grafting. Graft initially becomes white, then pinkens with the formation of new blood supply. Lymphatic drainage occurs or formed by the day 6. Collagen replacement from day 7 to week 6. Vascular remodeling occurs for even a month. Reinnervation occurs at 4 weeks but completes in 24 months. So the sensation pain returns first, followed by a light touch and temperature. So what are the factors affecting the graft take? The graft factors, environmental factors. The graft factors includes the thickness of the graft, vascularity of the donor area, and delays in applying the harvested graft. What are the environmental factors? The pressure, how much pressure is there, and how much we have immobilized the area. So graft bed factors depends upon the vascularity, the whether there is a good vascularity of a bone, tendon, or cartilage. While we have to prevent the infection in terms of streptococcus as well as irradiated bed and necrotic tissue. So what are the indications of the skin graft? So the wounds that cannot be closed primarily, we have to put skin graft in burn reconstruction, in scar contracture release, and FTSG is always preferred for a facial defect and child grow with. So FTSG always grow with the child and always reduce the risk of potential scar contracture. So what are the contraindications of skin graft? The absolute and relative. Absolute includes the avascular bed, infected wounds, and wound due to malignant neoplasia. Relatives are the pressure sore, irradiated wounds, wound due to vasculitis, malnutrition, and wound in cosmetically sensitive area. So the cortical bone without periosteum, cartilage without perichondrium, and tendon without peritoneum, these are the absolute contraindication for skin graft. We have to put some flap over this, but not skin graft. Infection caused by beta hemolytic streptococcus, an organism count of more than 10 to power 5 per gram of tissue, which should not go ahead with the skin graft. So there are some causes of the graft failure. The mechanical forces, the collection under the graft and the bed like hematoma and seroma. The mechanical forces, the collections, the infections as told earlier, and the various comorbidities such as diabetes mellitus, peripheral arterial disease, the infections, comorbidities. So this is my one representative case of a skin graft. These are the fully prepared bed over the lower 1/3 and middle third of the leg. So we put a skin graft, the mesh skin graft over this, and this is the post-operative result after 2 to 3 dressings. So thank you, and I will ask my colleague Dr. Rajiv Bharti boss to continue for the next presentation. Thank you.
Thank you, Dr. Niklesh Kumar Gao. Oh, actually, very excellent presentation. And graft is one of the most important things which all of us should know. And very nicely you had spoken. And as of now, till now, there are no questions whatsoever. So we ask the next speaker to continue. Dr. Rajiv.
For the next talk, I invite Dr. Rajiv Bharti, Assistant Professor, SGPGI Lucknow, for his talk. Is Dr. Rajiv with us?
Yes, he's here. Dr. Rajiv, you have to unmute. Unmute yourself.
Ma'am, Dr. Raju Bharti is having some problem. He's trying to fix it. So just give us some time.
Sure, sure. Sabasa, do we have? We'll wait.
Yeah, actually, otherwise, let him fix. Otherwise, I will try
Hello,
to put
hello.
something.
Hello,
He's come.
sir, good evening, sir, good evening. May I audible
Yeah.
now?
Yes, yes.
Sir,
Welcome, Dr. Bhatt.
Ma'am, thank you so much. Good evening, everyone. Sorry for the glitch happened. Myself, Dr. Rajiv, and I'm assistant professor here in the SGPGI in the Department of Plastic Surgery. Now, share screen. Hello.
So you're audible. Please
Ma'am,
share your screen.
I'm sharing my screen, but I'm not able to.
Sir, is there any admin issue, Sabasa?
Microsoft.
There is no admin issue, Farin ji. Actually, otherwise he
Yes.
can send it to this email. Actually, the email is
Dr. Rajiv.
ARSindia25
I'm just
gmail.com.
clicking on the share button.
No,
but,
you first stop sharing, log out and log in again, and then I'll tell you.
Okay, sir. Should I leave this session?
iPad की problem है वो.
Hello.
Rajiv,
Dr.
boss.
Rajiv, you first
Sir.
log out once and log in back.
Sir, if is my screen is visible there, but not my screen, no, sir. Only the camera.
You first log out and then log in back. Log
Okay,
out
sir. Okay,
with
sir.
this from the Zoom and again log in.
Okay, sir. I'm doing that.
Yes. Now you open your don't share screen. You open your presentation on your laptop.
Okay, sir.
Open that presentation on the laptop.
Sir. I opened, sir.
Now you start sharing and then they will ask you. Then you share that presentation. Don't share the whole screen.
Okay. Only. So I now open the Zoom meeting.
नहीं Zoom meeting है share screen को click करना click the share screen option.
Share screen option.
In the Zoom meeting.
In the Zoom meeting, ना sir.
Yeah.
सर एक ग्रीन कलर का शेयर बटन है बीच में नीचे पैनल
Ma'am,
में
share. I click
हाँ,
that button.
उस पे
So-
क्लिक करिए
There are something screen photo, share camera. Should I share the screen? No, it's not working. Ma'am, should I mail this presentation
Yeah,
to?
Sabha sir has just given you a mail address. Sabha sir, could you please give the address again?
ARS India ARS 25 India. ARS India 20 ARS India 25 at gmail.com.
At gmail.com. Sir, give me a second. I just send it to you.
Yeah.
Sir, I send it. Will you please check it? Hello, sir, I send it.
Yeah, we have not, it's not come. I'm just refreshing. It's not come. Yeah, now it has come.
Now it has come, sir.
Yeah. I just give me a minute.
Right, sir.
शेयर हो गया Now your screen, now your slides are visible.
Yes, sir. Yes, sir. Slides are visible, sir.
You can say next slide. I will keep changing it.
Okay, sir. Okay, sir. So next slide, please.
Make it full screen, Sabha. Just make it full screen.
Sir, it is full screen only. Are you able to see the full?
No, it is not full screen here. So you have to enable editing and then it will then you can change the screen.
Okay. Now is it full screen?
Yes, sir.
Yes, it's full screen now. You can start.
Okay.
Sorry once again for the glitch. Good evening, everyone. As is nicely discussed earlier by Ankur sir and ma'am and Nicholas, Dr. Nicholas, I'm now adding some more points to the flap. Now the history already described as it originated in 16th century from the Dutch word flappe. It means something that hangs having broad and loose and fastened only by one side. The description of the flap surgeries are way back in 1600 BC when in Sutusa Samhita described by Sutruta, and he reconstruct nasal defects by using cheek flaps. And during the First and Second World War, pedicled flap were used extensively. The next period occurs in the 1950s and 60s, where the surgeon reported using axial pattern flap with named blood supply. Next slide, please. And in the 1970s, distinction was made between axial and random pattern flap, and this was a breakthrough in the understanding of the flap surgery that eventually led to the birth of free tissue transfer in 1980s. Further advancement in the flap surgery comes in late in 1990s with the introduction of the perforator flaps. Next slide, please. Now the overview. The fundamental advantage of flap lies in their inherent blood supply, which ensures tissue viability and promotes optimal healing. Unlike skin grafting that already discussed is depend on the recipient bed for survival. Flap being in their own vascular network, making them suitable for challenging reconstruction scenario, including areas with poor vascularity, contaminated wounds, and also irradiated tissues. Next slide, please. Next slide, please. So now the classification is already discussed by Ankur sir and ma'am. Classification is based on form or composition, is also based on the location, attachments based on the perfusion of the flap, and also moment of the flap. Now I'm describing each one by one. Next slide, please. So the classification of flap, where the form or the composition is important, the flap may having only skin or fascia or muscle or bone, or the combination of the above. The next classification based on the location, that the flap may taken from the local area, that flap known as a local flap, uh, and regional flap, and if the flap is taken from the distant area, that is also known as free flap. Now the attachment having classified in two forms, one is free and one is pedicled. On the basis of perfusion, flap is classified as random pattern, axial pattern, free flaps, and now the most recent perforator flaps. Next slide, please. On the basis of the moment, flap can be divided into three: rotational flap, transposition flap, and advancement flap. So now on the basis of perfusion, as the diagram shows, the flap is divided into four: random pattern flap, axial pattern flap, free flaps, and next is perforator flaps. The diagram A shows random pattern flap, where the supply comes from the subdermal plexuses. This is the named artery, nutrient artery. There are the subdermal plexuses who supplied and make the major blood supply of the random pattern flap. Whereas in the axial pattern flap, the tissue or the flap supplied by some named vessel, and this is known as axial pattern. And if the axial pattern vessels or the perforator flaps are divided from the origin vessel, then it is known as free flap. And as of now, the perforator flaps are a small perforator, as described by ma'am, is supplying a piece of tissue. If we take that perforator and re-anastomose to a distant site, then it is categorized as a perforator based flap. Next slide, please. Now I'm describing each one by one. The random pattern flap is depend entirely on the subdermal vascular plexus for perfusion. It lacks a specific named blood vessel, and blood flow enters the flap base and travels through the network of small vessels within the subcutaneous tissue. Perfusion of these random patterns decreases with distance from the base. So the length and to width ratio is typically limited to 2:1 or 3:1. Next slide, please. So the clinical example of these flaps are like rhomboid flaps, bilobed flap, simple advancement flap, local rotational flap. The advantage of these flaps are these are simple design and execution, no need to identify specific vessels, reliable for small to moderate defects, and these are minimal preoperative planning required for this flap. Next slide, please. The limitation of these flaps are these are the size restricted flap because of the perfusion constraint, higher risk of distal necrosis if we don't follow the principles. Length to width ratio is having a major limitation, no suitable for large defect. Next slide, please. The next one is an axial pattern flap. These flap based on a named artery that runs along the long axis of the flap, providing direct blood supply and allowing a large, more reliable tissue transfer, allows for greater length to width ratio in compared to the random pattern flap. Next slide, please. Third one is free flaps. The examples, the advantage of the free flap is having preserved underlying muscle function. It large tissue volume available for these kind of flaps. These flaps have excellent blood supply reliability and minimum donor side mobility. The examples of these flaps are anterolateral thigh flaps. That flap is based on the lateral circumference femoral artery perforators, a deep inferior epigastric artery flap, superior gluteal artery perforator flaps, thoracodorsal artery perforator flaps, and many more flaps now being done as free flap. Next slide, please. The other limitation of free flaps, they are having complex vascular anatomy, require microsurgical skill, longer operative time, and steep learning curve for the microvascular training. Next slide, please. Now, on the basis of tissue composition, the flaps can be divided further into major 4 types: cutaneous flaps, faciocutaneous flap, myocutaneous flap, and osteomyocutaneous flap. Next slide, please. Now, the cutaneous flap. The cutaneous flap includes skin, epidermis and dermis, subcutaneous fat, and superficial fascia. The applications of these kind of supercutaneous flaps are simple skin defects, aesthetics reconstruction, area requiring thin pliable coverage, facial reconstruction where bulk is undesirable. Next slide, please. These are the examples. Examples includes bilobed flap for nasal reconstruction, rhomboid flap for trunk defects, or many other parts of the defect where VY advancement flap for small defects. This picture shows bilobed flap. This is the defect here, and the circular diameter is reflected next to the flap, and the prerequisite of these flaps are the lax tissue surrounding the defect, and the half of the length is again marked as this point, and these two flaps are rotated to cover the defect. That's why it is known as bilobed flap. Here in the second diagram, this picture shows the rhomboid flap. This flap is also known as Limburg flap, where the defect is made into a rhomboid, where these are the short diagonals and these are the long diagonals. The short diagonals having a angle of 120-degree, and the long diagonal having a 60-degree angle. So the flap was designed next to the short diagonal, parallel to the short diagonal. One line is drawn. This D and F, this line D and E is equal to this line, this defect short diagonal, and the same length of the one diagonal is also reflected to the next lateral border of the flap, and this flap taken and harvested along with its subcutaneous fat and all, and then transport to the defect side. Next slide, please. Now, the faciocutaneous flap, the composition of the faciocutaneous flap, all layers of cutaneous flap that already discussed, and plus deep facial layers. Is the deep including of deep fascia is enhances vascular network. Application of these faciocutaneous flap moderate side defect requiring durable cover, areas needed structural support, reconstruction over exposed bone or tendon, defects in high tension areas. Next slide, please. These faciocutaneous flap are classified by various surgeons. In 1984, the first description of faciocutaneous was done by Cormack and Lamberti. Classification, they classified into 4 types: A, that having multiple large one end arteries; just the B is having single large vessel supplying to the flap; the C, multiple small segmental vessels supplying to the flap; or D is osteomyofascial, supplying to the bone, muscle, and to the flap also. The second classification came in 1986 by Nakajima, and he described this flap into 6 types. These are the this is the direct cutaneous vessels. Now, the other type is second type is septocutaneous vessel. Third type is cutaneous branch of muscular vessels. Fourth type is perforating cutaneous branch from the muscular vessel. And the fifth type is septocutaneous perforators, and F is musculocutaneous perforators. There are 6 types of faciocutaneous flap described by Nakajima. Next slide, please. And the most recent classification of faciocutaneous flap comes in 1997, given by Mathies and Nahai. And this classification shows 3 types of perforators supplying to the faciocutaneous flap. One is direct cutaneous perforator supplying to the flap. Second one is septocutaneous perforator, and third one is musculocutaneous perforator. Next slide, please. The example of the faciocutaneous flaps are too many, but I'm just described few. One, anterolateral thigh flap, radial artery flap, lateral arm flap, scapular and parascapular flaps. Next slide, please. Now the myocutaneous flap, the composition is include, as the name suggests, myo and cutaneous. So skin, subcutaneous tissue, underlying muscle, associated fascia. That includes the robust blood supply because of the inclusion of the muscle. Application, large defect requiring bulk, dead space obliteration, functional muscle reconstruction, coverage of complex three-dimensional defects. Next slide, please. And this is the classification given by Mathies and Nehai for the musculoskeletal flap. These flaps are divided into or categorized into 5 types. Type 1 is having a major vascular pedicle dividing. These flaps, the classification based because of the vascularity. The different type of vascularity is leads to the different type of classification of this flap. So the type 1 is having a one major pedicle. The one major pedicle supplying this vessel, this muscle, and the example is tensor fascial lata flap. The type 2 having one major, this is one major, this is one major, and this is two minor. These are the minor maybe 2 or 3 or something. These are type 2. The example of this is gracilis muscle flap. Type 3 is having two major, 1 and 2. These are dominant major vessels. This supplies to the muscle, and the example is gluteus maximus. Type 4 is segmental. Segmental means the segment of the entire muscle is supplied by a segmental branches of the perforators, and the example is sartorius. And the type 5 is latissimus dorsi, is a type having major vessels and multiple segmental vessels. So these are the myocutaneous flap classification. Next slide, please. The examples of the musculocutaneous flap is latissimus dorsi myocutaneous flap, pectoralis major myocutaneous flap, rectus abdominis myocutaneous flap. Next slide, please. The next one is osteomyocutaneous flap. Osteo is bone, myo means muscle, and cutaneous means the skin. The composition is having all soft tissue components, bone segment, periosteum complex. It is having complex vascular supply. Here the diagram showing the free fibular flap harvest marking. This line is the marking of the skin paddle. This skin paddle is attached to a septum, that is a posterior septum of the fibula, and along with this skin paddle we harvest this bone. This is the fibular bone along with the muscle. If we need, then the FHL muscle can be taken with this flap. Next slide, please. Our examples is fibula osteocutaneous flap, iliac crest osteomyocutaneous flap, scapular osteomyocutaneous flaps. Next slide, please. Now the types of flap categorized according to the moment. Moment is divided into advancement, rotation, transpositional, and another is interpolation. Next slide, please. So the advancement flap, these are the flaps. These are the flap based on the moment is very important for the surgeons who are dealing with the peripheral centers. Like this advancement flap, the defect is created and formed into a rectangle, and the prerequisite of these flaps are the loose skin tissues is must to be available adjacent, and the parallel incisions are given, and the flap is advanced in the direction of the defect directly. If having any issue or some tension is there, then a Burroughs triangle, a triangular structure, triangular skin is taken out from the both of the corners of the flap, and it gives an ease of the advancement of the flap. Or you can also give a back cut. This is the back cut in the C diagram showing if we are having any difficulty to mobilize the flap, so some sort of mobility is gained by the Burroughs triangle and the back cut. So the moment characteristics of these flaps is direct linear movement into the defect, no rotation or lateral displacement, tissue advance, straightforward, maintain original tissue orientation. These are the movement characteristics. Design principle of this flap require adequate tissue laxity, length determined by tissue elasticity. Width should be accommodate close without tension. No require and may require backcut or Burroughs triangle. Next slide, please. So the clinical application of the advancement flap that's having linear defect, areas with good tissue mobility, situations requiring simple, reliable closure, defect where tissue orientation is important. The common example of the advancement flaps are VY advancement flap, A to T advancement flap, bilateral advancement flap, single advancement flap, and with backcut. Next slide, please. The advantages of this flap are simple design and execution, maintain tissue characteristics, uh, minimal distortion of surrounding structure. The limits by tissue elasticity may create standing cones not suited for large defect, require adequate surrounding tissue. Next slide, please. Next slide, please. The next one is the rotation flap. These flaps like advancement flap, rotation flap, these are and the transposition flaps are the most common used pedicle flap in everywhere in the plastic surgery. So the rotation flap is a curved moment around a pivot point, and I'll just discuss and describe this flap. If there is sort of lesion here or something, some defect, so first and foremost thing, to triangulate the defect, we need to triangulate the defect, and by the measuring the base, this is the base, and this base is reflected 5 to 7 times to just mark an arc. This is the arc, this is a large arc, and this is 5 to 7 times to the defect base, and this base is reflected twice or more than 2.5 or 2 times to the this base to create a center point. And this center point, the distance between the center point and the edge of the defect is a radius. So by doubling this radius, we are getting the diameter of the rotation flap, and the flap is rotated by making a large arch. The prerequisite of this flap is also a lax tissue is should be available around the defect. And this flap once sutured after closure then looks like this, and this is the line where the greatest tension happens, and this X is a pivot point where the maximum tension happens, and the arc of rotation of this flap happen. So can you please next slide, please. So the clinical application of this flap is curved or circular defect, scalp reconstruction, area where curved scars are acceptable, situation where abundant adjacent tissues. Now, example, scalp rotation flap, we are using more frequently in scalps, cheek rotation flap, tongue rotation flap, and modified rotation flap with advancement. Next slide, please. So, this limitation of these flaps are they may create dog ears, and curved scar may be noticeable, requiring careful planning, potential for teardrop deformity. And the advantages can cover large defect, utilize abundant tissue reservoir, good blood supply, maintain versatile design options. Next slide, please. The next one is transposition flap. This is also a very common and important flap as a pedicle flap. So if there is a defect, then this defect should be triangulated. The triangulation is important thing to do for the planning, and by measuring this the length of these diagonals of the triangle, we measure the length according to the defect, and we just rotate the flap, we harvest the flap along with the tissue, subcutaneous tissue and all, and we rotate this flap to cover this defect. And the disadvantage of the transposition flap is that the secondary defect created here and that is to be grafted. And this is not a point in the rotation flap where no grafting is required. But in the transposition flap, the secondary defect created by rotation of the flap that needs a grafting. So the design principle, the flap must be larger than the defect. Consider tissue thickness matching. Plan for secondary defect closure, and geometric precision is important. Next slide, please. The clinical application, defects where direct closure is impossible. Areas requiring tissue from different orientation, complex geometric defect, situation with limited local tissue. Common examples are the rhomboid flap, bilobed flap, Z-plasty flaps, defermental flap. Next slide. The advantages of this flap are precise geometric design, predictable outcome, can utilize distal tissue, excellent for facial reconstruction. Limitation of this flap is complex planning required, may create multiple scar, risk of flap necrosis, and requiring geometric precision. Next slide, please. Now the next is also a very common and very interesting flap is interpolation flap. The difference between the interpolation and the transposition is a sort of transposition. Interpolation flap is a sort of transposition flap, but the basic difference between interpolation flap and the transposition flap is that the interposition flap, there are some normal tissue reside between the defect and the flap. So the moment characteristics of this flap crosses over intact skin bridge, requires stage division. This is a two-stage, most likely two-stage procedure. Maintain connections during healing. The design principle, robust blood supply is essential. Planned for pedicle division time, usually 2 to 3 weeks. Consider patient compliance. Aesthetic planning is crucial. Next slide, please. So this is the picture of our patient, is showing that the defect, this is the defect of the nose, and it is a composite tissue defect. And for this type of defect, we planned our forehead flap. So forehead flap is a type of interpolation flap. Here, this blue dot is a marking of the flap. So this is the body of the flap, and this is the pedicle of the flap, skin paddle. So this where the incision are given, and the flap is harvested above the periosteum. This is the periosteum, and periosteum should not be elevated along with the flap. And this is the flap, goes deep to the frontalis muscle, and here in this flap is harvested here under the forehead muscle, frontalis muscle. And in the third diagram, the rotation or the reach of the flap is addressed here in the fourth diagram. And this 5/5 diagram shows the excellent settling of the flap. And this is the unpleasant, unaesthetic presentation of the flap. This looks like a trunk. And here this is a two-stage procedure I already mentioned. So in the second stage, after 2 to 3 weeks, we divide and suture the upper edge of the flap here, and the restoration of the forehead structures have been done. So the clinical application, defect distal from the tissue source, complex facial reconstruction, area requiring specialized tissue. The common example are forehead flap, as I already described, nasolabial flap, cross finger flaps, and temporal flaps. Next slide, please. The advantage of these flaps are access to distal tissue, excellent tissue match possible, reliable blood supply. The limitation is it is a two-stage procedure, patient compliance required, temporary aesthetic concern, risk of pedicle injury is there. Next slide, please. Now the clinical application and selection of flap. Successful local flap reconstruction require systemic evaluation of multiple factors to select the most appropriate technique for each clinical scenario. This decision-making process integrate the defect analysis, patient factor, technical consideration to optimize outcome. Next slide, please. And the evaluation of flap selection has moved from simple algorithm approaches to sophisticated decisions making framework that consider long-term functional and aesthetic outcome. This is the diagram shows the reconstructive ladder. Here, the 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 lower part of this diagram shows the less complex or the simpler procedures or the planning for any defect, and the higher or the upper things are shown at the complex or the various difficult procedures in plastic surgery domain. So the very bottom, it shows us allowed wound to heal by secondary intention. If it is not feasible, then direct tissue if that tissue closure is possible, then it is followed. If it is not, then skin grafting is followed. If the bed is not good and there are sort of infection, then we go for the local tissue transfer. And if there is no laxity in the local area or some sort of vascular insult in the local tissue, then we go to the regional tissue transfer. And if it is also not amenable or treated by the regional tissue transfer, then the final or the technical option of the free tissue transfer is to be considered. Next slide, please. Now the defect analysis framework, the size consideration of if the categorized by small defect, medial or large defect. Isn't this the defect is small, the simple advancement or small rotation flaps to be planned. If the defect is medium size or 2 to 5 centimeter in size, then transposition flap or larger rotation flap can be planned. If the defect is large, more than 5 centimeter, complex flap, multiple flaps or alternative techniques or the free tissue transfer is to be considered. Next slide, please. The other factor is the location factor. We have to follow the principle. If the facial defect, then aesthetic subunit principle is to be considered. The face is divided into, as we all know, face is divided into major 9 unit, and these 9 units are further subdivided into various subunits. And the tissue match priority is very important. For the trunk defects, the functional consideration is important, and scar placement, where the scar is going to place. So we generally try to place the scar in the concealed area. Extremity defects, for the extremity defects, we have to consider about the joint function preservation and durability requirement. For the scalp defect, hair bearing tissue consideration and large tissue availability is considered. Next slide, please. For the depth requirement, for if the defect is superficial, then cutaneous flaps are adequate. If having dealing with the deep defect, then faciocutaneous or myocutaneous flaps are required. For bone exposure, muscle flaps or the complex reconstruction needed, or composite tissue defects, multiple tissue flaps or stage procedure can be taken as consideration. Next slide, please. The patient factor consideration, there are medical factors that limits the viability or the survival of the flap. That includes, these are the relative sort of things: age, any comorbidity like diabetes mellitus, hypertension, or any peripheral vascular disease, any history of chronic smoking, previous surgery or radiation affecting tissue quality, medication affecting healing or bleeding risk. Next slide, please. The decision-making algorithm. There are defect assessment. The defect assessment is evaluate the size of the defect, depth of the defect, location where the defect is located, surrounding tissue quality. That is a very important point to determine the reconstructive requirement. The second very important aspect in decision making is patient evaluation. Assess the medical status of the patient, functional need of the patient, aesthetic goal, what the patient need, and compliance potential. Third important thing is option analysis. Consider all viable flap options. Evaluate the advantage and limitation of each approaches. The fourth important thing is risk benefit assessment. Compare complications, rates, functional outcomes, and aesthetic results of each option. The fifth is final selection. Choose the optimal technique based on the comprehensive analysis and patient preference. Next slide, please. Next slide. Now, the fundamental design principle. So, for design principle, the mathematical relationship ensure optimal tension distribution. Specific angle and proportions minimizes complications. Precise measurement prevents size mismatch. We need to measure regularly and repeatedly before giving any sort of incision. And once we are sure that this flap is going to cover the defect, then only we uh, uh, give incision. Geometric planning reduce revision requirement. Now, the vascular consideration, blood supply orientation determines flap viability. It is very important. Pedicle width affecting perfusion reliability. Vessel location influences design modification. Perfusion assessment guides size limitation. Next slide, please. The third is tension vector analysis. Force distribution affects healing outcome. Closer tension determines complication risk. Vector planning prevents distortion. Tension reduction techniques improve result. Aesthetic integration, subunit boundaries guide incision placement. Natural contour influences flap orientation. Scar camouflage technique improve appearance. Symmetry consideration affect design choice. Next slide, please. Now, some common design error. The inadequate blood supply. If we plan our flap a narrow pedicle length that leads to the venous congestion, or if we not measure it properly and we excessive flap length causing distal necrosis. If we not orient properly, there is a chance of kinking, and insufficient perfusion assessment is very important before designing any sort of flap, whether it is a random pattern or axial pattern or flea flap. Certain geometric mistake, incorrect angle calculation in transmission flap, inadequate size planning lead to tension, poor proportion relationship causing distortion, measurement error affecting closure. So these are the geometric mistakes. Next slide, please. Aesthetic oversight, crossing aesthetic subunit boundaries is unnecessary, creating unnatural contour or asymmetry, poor scar placement in visible area, or ignoring hair growth patterns. These are the aesthetic oversight, and this should be avoided. Next slide, please. Certain strategies to prevent complications. So adequate pedicle width, minimum is 1:1. That ratio is for the random pattern flap, and that may varies to 1:2 or 1:3 for the random pattern flap if we are planning these flaps in the leg. And gentle tissue handling to prevent vessel injury, proper flap positioning to avoid kinking, post-operative monitoring for perfusion. So precise template creation and measurement is important. As I already tell, tension assessment is throughout the procedure. Next slide, please. Respect the aesthetic subunit boundary. That is very important, and this is significantly important in the face, where everything is visible to the relatives or the next person, to the patient. So always aesthetic subunits it should be taking as a consideration when we are planning any flap to the face. Symmetric design planning is also important. Natural contour preservation and appropriate scar placement is important. So all the lines along to the face is rested on the resting tension skin line, so the scarring is less happen. Next slide, please. So to conclude, we go through certain things. Then overview: understand that flaps are tissue transfer with their own blood supply. offering superior outcome to skin graft through better color match, contour, and reduced contracture. Blood supply classification master the three main blood supply types: random pattern, that is subdermal plexus axial pattern, and perforator base or the free flap vascular supply. Tissue composition category learns the progression from simple cutaneous to the complex osteomyocutaneous flaps. Next slide, please. The movement pattern type, understand the four primary movement pattern, that is advancement, rotation, transposition, and interpolation, each with specific geometric requirement and clinical application. Clinical application and selection: develop systemic approaches to flap selection based on characteristic tissue and design principle and complication. Master the fundamental principles of flap design, including tension vector, aesthetic subunits, and blood supply pattern to prevent common complication and achieve optimal outcome. Next slide, please. These are the references for my this presentation. Next slide, please. Thank you so much for being patient and listening my presentation.
Thank you, Dr. Rajiv. That was an extensive and a very in-depth presentation on flaps. Dr. Sabha, are there any questions online?
No questions, Farin. So there is no issues. So we can ask Ankur sir for the concluding remarks, and already Dr. Sanchit is there, so he can.
Okay, thank you, Dr. Sabha and Dr. Fareen for being there for us. And this was in a nutshell the basics of plastic surgery, which we wanted to present to our various rural surgeons. And any queries, anything which they come up, they can always contact Dr. Sabha, and he can forward us the queries and we'll reply to it. And on behalf of all our speakers from the plastic surgery department, I would like to thank the Association of Rural Surgeons of India, especially Dr. Sabha, for inviting us. And thank you very much. And do keep in touch. Thank you.
Thank you, sir.
Thank you,
Thank
sir.
you.
Thank you. I would like to thank Dr. Sabha, Professor Sabaratnam sir, for making me part of this conference. Thank you, sir.
Thank you so much. So once, like, if any questions, we'll get back to you. And this Zoom platform is mainly for faculty. So I request now the moderator of the next session, that's on urology. So I request Dr. Sanchit Rustagi, who's an additional professor in the Department of Urology. He'll be the main moderator of this session. He'll be talking on renal stones also. But the first talk will be by Dr. Arpan Yadav, which will be on carcinoma prostate. Then Dr. Ashish Ranjan will talk on BPH, and third will be Dr. Sanchit. Sanchit, you will please take over, and you can introduce your speakers, and then they can start speaking on the topic.
Okay, so good evening, everyone. Thank you for giving us the opportunity to speak in this platform. We are three speakers in total. I myself, Dr. Sanchit Rustagi, I am Associate Professor in Urology and Renal Transplantation at SCPGIMS. I will be talking on renal stones. My colleagues are Dr. Arpan Yadav, who is an assistant professor in the department, and he will be giving us a brief talk on CA prostate, carcinoma prostate. And in between or later off, we have Dr. Ashish Ranjan, who is also assistant professor in the department, and will be talking upon the tips and tricks to manage benign prostatic hyperplasia. So I will like to invite Dr. Arpan Yadav to first give his talk. Dr. Arpan, please.
Thank you, sir. Sir, am I audible?
Yes, you are audible.
Okay, sir. I am just sharing my screen. Just wait for a while. My screen is visible, sir?
Yes.
Yes.
So good evening, everyone. So I'm Dr. Arpan Yadav, Assistant Professor in Department of Urology and Renal Transplant, SGPGI Lucknow. So today I will be speaking about carcinoma prostate. Actually, this carcinoma prostate is the major topic in urology, and most of the research which is going presently is on carcinoma prostate. So it is very difficult to cover it in one go, but as sir told me that we have to stick to the basics. So we will be covering our slides under following headings: epidemiology, very basic about the screening, whether population-based screening or individual screening. And more, I will be talking about the detection and diagnosis, which is important, especially when we are in periphery, and staging pathology, and very briefly about the treatment of carcinoma prostate. So moving on, carcinoma prostate is second most commonly diagnosed cancer in men after lung cancer, and the prevalence increases with age. So in age more than 80%, it has been said that 60% patient can harbor carcinoma prostate when autopsy is done in any form, in a low grade fashion, but around 60% patient may have this carcinoma. So highest incidence is in Australia, New Zealand, North America. Our Indian subcontinent is in between as per the incidence is concerned. The main problem is that in Western birds, 66% patients present in localized stage and 7% patient present in metastatic state. But on the contrary, in India, 42% patient, this is the National Cancer Registry data, that 42% of our patient, they directly present in metastatic state. So this shows a lacuna in patient awareness and also the lack of adequate suspicion and lack of individual screening in our healthcare system, especially in the peripheries where the treating physicians or maybe the treating surgeons may not be able to diagnose carcinoma prostate in early stage. So they generally present in 40 to 50% cases, they present in late stage. So coming on to the etiology, so risk factors, increasing age is definitely a risk factor. I have explained. Metabolic syndrome, hyperlipidemia, hypercholesterolemia, obesity, hypertension have increased risk of carcinoma prostate. African American is not a risk factor for carcinoma prostate, but in those races, the cancer is more aggressive and the prognosis is worst. Obesity, I have already told. Dietary factor, there are certain dietary factors which can decrease the propensity of having carcinoma prostate, and certain dietary factor which can increase. So low fat diet, lycopene in diet, selenium, zinc intake, they may curtail the possibility of carcinoma prostate. Then in etiologies, around 18% carcinoma prostate patients has family history or have hereditary prostate cancer, or we can say have germline mutation. So in these patients who have hereditary carcinoma prostate, they have an early onset disease, they have a high grade disease, and also the prognosis is also worst in comparison to normal idiopathic variant. There are many susceptible genes. Most of them are tumor suppressor gene. Notably, some I have mentioned: BRCA1, BRCA2, ATM, P53, and CHEK2 gene. So majority, the most 95 to 96% of prostate cancers are adenocarcinoma, and they develop in the SSNI of the prostatic duct. There are many rare histological types which we have seen commonly, that we have seen are small cell carcinoma, transitional cell carcinoma, we have seen squamous cell carcinoma, we have seen. Recently, we have operated one case of basal cell carcinoma also, and neuroendocrine cancer. In these rare histological variants, mostly there are very few variants which are less aggressive than adenocarcinoma. Mostly variants are more aggressive than adenocarcinoma, but only good thing is that they are very rare. So location wise, we all know that prostate have peripheral zone, transitional zone, central zone, and anterior fibromuscular zone. So the most common carcinoma prostate arise from peripheral zone, 70 to 75%. Transitional zone harbor 25% of cases, central zone 5%, and anterior fibromuscular zone very rarely there is a foci of carcinoma prostate. So the main cause behind this, why it is arising from peripheral zone, I think that 80% of the ductal system of the prostate carcinoma is in peripheral zone. It has also been found that the genetic makeup of the peripheral zone also differs from the other zone of the prostate in a way that it increases the propensity of the carcinoma prostate. Third, peripheral zone is the most posterior zone of the prostate. So the diagnosis is also easy. It can be easily picked up on DRE, and the biopsy, the conventional route of biopsy, that is transrectal biopsy, we can easily take biopsy in peripheral zone. So detection of cancer is also easy from peripheral zone. So clinical manifestation, our patient, when they present, they may be asymptomatic. Most of our patient present with obstructive voiding symptoms, that is slow stream, hesitancy, intermittency, and incomplete voiding or incomplete micturition. They may present with hematuria, hematospermia, maybe in locally advanced cases. Patients with metastasis to lymph nodes may present with edema of the lower extremities, pelvic and perineal discomfort, bone mets, which are very common in carcinoma prostate, and they are typically osteoblastic or osteosclerotic mets, which happens. And more often than not, patient to us present with bone pain, paraparesis, or vertebral fractures. So this is also one most common of presentation, especially in public healthcare sector in India. Patient with chest mets can have breathing difficulty due to effusion, may have cough, hemoptysis, or may have brain mets, so they may manifest CNS symptoms. So screening, which is important. So screening is systemic examination of asymptomatic men to identify individuals at specific risk. So the population screening, which is the case for most of our cancer like breast cancer or CA cervix, I think, but population screening is not recommended in carcinoma prostate because risk to benefit cost wise, it is very cumbersome, and the risk of picking low grade cancer which are not clinically significant is more. So population based screening is not recommended. You have to do individualized risk adapted screening to the two categories of patient. One patient who comes to you with lower urinary tract symptoms. In those patient, after informed consent, we can screen the patient. And in second category is the patient is in anticipation whether his distant relative, his first degree relative having carcinoma prostate, or his someone from his known have carcinoma prostate, and if he comes to you, then we can screen that patient. That too, for normal individuals, we have to do individual screening in men for age 50 and more. Patients who have family history of carcinoma prostate or having African descent, then we may start this individualized screening from 45 years of age. And men who are having a known mutation of BRCA1 or BRCA2 mutation, then in those patients, we can start the screening from as early as 40 years of age. So I want to make a point that population screening is not recommended for CA prostate. We have to do individual screening. So now coming on to the detection and diagnosis. So our first tool is DRE, digital rectal examination. So 18% cases are detected by suspected DRE alone. So in patient who are having PSA less than 4, the DRE only has a positive predictive value of 5 to 30%. In general, average is 18 to 20%. So an abnormal DRE is associated with increased risk of higher grade of the tumor. It has been seen if you can feel the tumor, then the grade of the tumor is more. And the next statement, ironically, still the T staging, the TNM staging which we have, or the EUA risk stratification is still dependent on DRE. Though more often than not, we are using MPMRI for better anatomical delineation and better staging. But still in literature, they have said that the TNM staging is based on DRE finding, which we will see will change in near future. We are hoping, because most of us are not using DRE as a sole measure of deciding whether we have to go for surgery or whether we have to give neoadjuvant therapy. So it needs change. So our second tool and most important tool is prostate specific antigen. So this serum marker has revolutionized carcinoma prostate diagnosis and follow-up. So we have to remember that PSA is organ specific, not cancer specific. So it can be elevated in all prostate conditions like BPH, prostatitis, and other non-malignant condition like UTI, even acute urinary retention. So diagnostic accuracy of PSA more than 4 for detection of carcinoma prostate is around 50 to 70%. Diagnostic accuracy of PSA more than 10 nanogram per ml is around 80 to 90%. And when we add PSA and DRE hand in hand, so diagnostic value of PSA more than 4 and abnormal DRE is around 90%. But the problem arises when the PSA is between 4 to 10 and we have normal DRE findings. In these borderline cases, the decision making of having a biopsy or to skip a biopsy can be done on the basis of, most commonly we are using MP-MRI. PSA density may help, free PSA values may help. There are certain urinary test and blood test which we can also do, though they have very weak recommendation, like prostatic health index, 4K test, Stockholm test, which we can use to direct ourselves in these borderline cases, whether we have to proceed for biopsy or we have to skip biopsy. So this is very important chart that a patient with LUTS comes to you with high PSA and you have done DRE and DRE is normal. So we have to remember, always ask for a temporal association of any febrile UTI, any history of acute prostatitis, any history of chronic prostatitis. They are very, very common in India. And also a history of recent acute urinary retention or a very high PVR. We commonly see PSA values of 70, 80, even 100 we have seen in these cases. And when DRE is normal, our dictum is you just drain the bladder, you give them infection specific antibiotic for 4 weeks, you repeat PSA, and we have seen in 20 to 30% cases PSA has come down to normal. So always remember, high PSA with a normal DRE and with temporal association with any of these factors, always drain the bladder, give antibiotic and repeat a PSA before proceeding further. So our next tool in detection and diagnosis is multi-parametric MRI. So MRI, what is multi-parametric MRI? Multi-parametric MRI is MRI combined with different imaging sequences. That is, routine MRI sequences are T1, T2. If we combine them with diffusion weighted imaging, ADC imaging, contrast enhanced imaging, or in some case spectroscopic imaging, then they are multi-parametric MRI. And there are mainly three present scenario. There are three roles of MP-MRI. Number one, they helps in anatomical delineation, so helps in staging the disease, which I have discussed. They also guide biopsy decision in borderline cases, which I have discussed. And third is MRI fusion biopsy. The trend has changed from systemic biopsy to targeted biopsies. So they also help in MRI fusion biopsies, which I will explain later also. So these are the three main role of MP-MRI in at present in our practice. So on the MP-MRI reports Pirates. Pirates is prostate imaging, recording, and data systems. So we have to remember when we get such type of MP-MRI reports. So the thumb rule is Pirates 3 and above. That is Pirate 3, 4, 5. You have to get the biopsy done. There is a very small subset of patients in Pirate 3 lesions who have PSA density less than 0.1. Who have normal DRE, who have very small Pirates 3 lesion, especially in the central zone. In those patients, the biopsy can be skipped, but the thumb rule is if it is Pirate 3, 4, 5, you have to do the biopsy. So this is the latest TNM staging. So I think you have to remember the basic that whatever less than 5, more than 5, one lobe, half lobe, you have to remember that T1, T2 is localized disease. T3 is locally advanced. So it has breached the capsule. It is T3A. When it is involving the nearby structure, seminal vesicle is T3B. And disease beyond that is T4. Lymph node staging is simple, N0, N1, if lymph node are present. And metastatic disease, M1A is non-regional lymph node, except for pelvic nodes. If there is any lymph node is M1A disease, bone mets is M1B disease, and other mets and mets to other viscera is M1C disease. So further in detection and diagnosis, the prostate biopsy. In prostate biopsy, I want to focus on two things. One is there are two types of prostate biopsy. One is systemic biopsy and other is targeted biopsy. In first diagram, you can see systemic biopsy. What is systemic? The present standard is 12 core systemic biopsy. So systemic biopsy is that you have to take systematically 12 cores from all the nukes and corner of the prostate. So you have to divide right lobe, left lobe. Right lobe is further divided into lateral medial part, upper, middle, lower. Like that, you have to take 12 biopsies. So before the advent of MRI, our practice is for systemic biopsies. But problem with systemic biopsy that in a diagram you can see that suppose we have a pyrite 4 lesion as shown in the diagram. And now we have taken these 12 biopsies. So there is a high amount of high chances that we may miss the cancer, or we may take a very perilesional biopsy, which may show the cancer, but may not be the exact grading of the cancer. The Gleason grading may be less because of the distant tissue. So MP-MRI targeted biopsy, the momentum have shift towards the MP-MRI targeted biopsy. So MRI targeted biopsy can be done by three methods. One is cognitive biopsy. Cognition is you see the MRI report, you see the MRI on the console, you picture that lesion in your mind that this right lobe, upper middle part, this lesion we have, and then with the help of ultrasound, transrectal, you can take the biopsy. Second is there are software available with ultrasound in which MRI films are overlapped with the real-time ultrasonological images, and the biopsy can be taken in that guide. And third is MRI bore guided, in which the biopsy is taken under the MRI guidance. So the later two types, they are available in India, but they are not available in Lucknow and in our institute. So mostly whatever we are doing targeted biopsies on the basis of cognition. And in targeted biopsy, you have to remember that 2 to 4 biopsy you have to take from the lesion and 2 to 4 perilesional biopsy. So for one lesion, you have to take 7 to 8 biopsies. Second important thing in prostate biopsy is that two routes we are taking prostate biopsy. One is transrectal biopsy, which we are commonly doing, and transperineal. Advantage of transrectal biopsy that they are easy. I think not easy, but we are pretty much trained in transrectal biopsy from our residency days. Plus, most of the cancer are in peripheral zone, so the posteriormost part of peripheral zone is easily accessible, and also it is least painful. So no local anesthesia, no regional anesthesia is required. The major disadvantage is the most common side effect, or the major side effect, most dreadful side effect of prostate biopsies are febrile UTI and prostatitis. Though occurrence is very less in 2% of cases, but acute prostatitis has a high mortality and morbidity, which is a dreadful complication. So chances, because our true cut needle is going through the rectum, so chances of prostatitis is far more via transrectal route. So this is the major disadvantage of transrectal biopsy. That's why we are now shifting to the transperineal biopsy. In transperineal biopsy, this is the predefined cassette we have, that brachytherapy cassette we use. The ultrasound goes in the rectum only, but TrueCut gun takes the biopsy from the transperineal route. It has the difficulty is that one problem with that, it is slightly more painful than transrectal biopsy. So we may need local anesthesia. Even some cases in apprehensive patients, we need regional anesthesia. And second, the problem is that we are not very much accustomed of doing transperineal biopsy. And also the one of the advantages that it has less infections, and the anterior fibromuscular zone, or the anterior part of the prostate, is more accessible with this transperineal biopsy method. So when we send this biopsy to our pathologists, so depending on the architectural pattern of the tumor, they give Gleason grading 1, 2, 3, 4, 5. In this ISOP consensus 2014, the Gleason grade 1 and 2, they have been scrapped. So only Gleason grade 3, 4, 5 are the grades which they are presently reporting. And on the basis of grading for biopsy, we give Gleason score. So Gleason score consists of the most common grade plus the second most common grade, which gives us the Gleason score. So this is ISOP grade group. ISIP is International Society for Urology Pathology. So minimum Gleason score possible is 6 because we have 1 and 2 are scrapped. So 3 plus 3 is the minimum. So they come in grade 1. If most common pattern is 3, second most common is 4. So ISUP grade 2 is Gleason score 7. And the vice versa, if most common pattern is 4 and second most common is 3, is ISUP grade 3. If your Gleason score is 8, then you have ISUP grade 4. And subsequently, ISUP 5 consists of score 9 and 10. So we risk stratify carcinoma prostate on these bases. So broadly, there are low risk, intermediate risk, and high risk. These are the risks which we define mainly for localized disease. So low risk, important is the word end. For patient being a low risk localized cancer, ISUP grade should be 1, PSA should be less than 10, and the staging should be less than T2A. For intermediate and high risk, the important word is or. If any of the factors is there, then they should be categorized in that respective risk group. So ISIP group 2 and 3, PSA 10 to 20, and staging T2B. They are intermediate risk group, and high risk are ISUP grade 4 and 5, or PSA more than 20, or stage which is more than 2 T2C. They all come in high risk group. So now the last nail in the coffin of detection of diagnosis is metastatic workup. So the thumb rule for that is what we use in metastatic workup. So PSMA PET has a greatest sensitivity and specificity. Only problem is it's very expensive and it's not readily available. So in those patients where PSMA PET is not available, guidelines still says that you can very well go for a bone scan and a CECT abdomen plus pelvis plus thorax. So in what category of patient you have to do a metastatic work before proceeding to surgery or any primary treatment? So in intermediate risk disease and high risk disease, before going further to any treatment, we have to do a full metastatic workup done. So this is the flow chart of detection and diagnosis. And I have this last slide on the treatment because the treatment of carcinoma prostate is very vast. So I will give just a very brief idea that low risk localized disease, there is an option of active surveillance patient, the patient in which life expectancy is more than 10 to 15 years. Patient we can put on active surveillance. In this patient, we can do re-biopsy. And if there is any sign of disease advancement at that time, we can intervene. Or in patients whose life expectancy is less than 10 years, in those patients, watchful waiting is most optimal. In intermediate high risk localized cancer, we have radical prostatectomy, which we can do by open method, by laparoscopy, by robotic. We also primary external beam radiotherapy also have very good results with or without adjuvant therapy, which we will decide on when we get the final histopathology. Now, metastatic disease, we have two types. In hormone sensitive metastatic disease, so we have to curtail the testosterone. The pathophysiology of cancer prostate is mainly related to testosterone. So bilateral orchidectomy we can do with them. First and second line hormonal therapy we have. So we can give them GnRH agonist, GnRH antagonist, anti-steroidal anti-androgens we have, steroidal or non-steroidal anti-androgens we have. And since bone mets are very common, so we have many drugs for bone health like bisphosphonates. And sometimes this cancer, when they become castration resistance, so also we have option of chemotherapy, docetaxel, cabazitaxel. In BRCA mutated patient, we have option of PARP inhibitors. The next in line is lutetium therapy and immunotherapy. And there are some immune vaccine which we are giving in carcinoma prostate. So that is all from my side. Over to Sanchit sir.
Thank you, Arpan. Thank you for a elaborative presentation. Since carcinoma prostate is a very vast topic, I am very thankful to you to present the main points for the detection and when to refer a patient, when to diagnose, when to screen, and when to treat the patient. Thank you. Now I will be making the next presentation. I will ask you to please stop your screen sharing so that I can share my screen. So good evening, everyone. My name is Dr. Sanchit, and I am a associate professor in the Department of Urology and Renal Transplantation, SDPJ Lucknow. I will be speaking about renal stones. The topic of my talk will be tailoring renal stone surgery in precision endourology, from prone to supine and from standard to ultra mini and beyond. The incidence is 12%. We have a stone belt which includes Punjab, Haryana, New Delhi, Uttar Pradesh, and parts of Bihar and Bengal. And the incidence of stone disease here is 15 to 20%. Moreover, we have seen that the recurrence rate in the stone belt is 50% within the 5 years, even if the patient has undergone complete clearance of the stones. The annual incidence has been seen to be increasing over the past 2 decades. Coming on to pathophysiology of stone formation. Why does a renal stone form? We can see that this is a cut section of a kidney where outer cortex and inner medulla, the pelvis and the ureters. There urine becomes concentrated as it passes through the kidney. Calcium salts and other chemicals may crystallize and leading on to formation of kidney stones. The calculus is usually the size of a pebble to start with, and gradually, due to supersaturation, the size increases and may increase to size such as to cause complete obstruction of the renal pelvis. Now, coming on to history of renal calculus disease. Initially, we have seen that we have been clearing the stones by using a nephrolithotomy incision or a pyelothotomy incision. What is the basic difference between a nephrolithotomy or a pyelothotomy incision is when we cut the renal parenchyma, we call it as a nephrolithotomy. And when we extract the stone by giving incision over the pelvis, it is known as a pyelothotomy incision. The first nephrolithotomy dates back to 1880 to name of Sir Henry Morris. History of renal calculus management. The first rod length system came into existence in 1960s. It was developed by Sir Harold H. Hopkins. In 1974, ESWL was developed, and the main person behind it was Sir Christian Chauzy. And then in 1976, there was performance of first PCNL, which was performed by Fernstrom and Johansson. In this video, one can see how a ESWL machine works, that the patient is lying in a supine position under the image guidance of an ultrasound, and the lithotripsy are given so as to cause lithotripsy, and then there is occurrence of stone clearance. ESWL versus PCNL. ESWL initially, in the initial part, after its coming, it was in great talks, and PCNL was being performed at a fewer centers. But as the time progressed, it was seen that ESWL is associated with a few problems, as like the stone clearance rate was only 60%, multiple sittings were required, there were risk of hematoma. And as you can see in the X-ray or the top left side of the screen, the after stone clearance, there is formation of a Steinstraus, which requires multiple settings or multiple interventions like a URSL so as to cause complete clearance. On the other hand, PSNL with time gained weight as there was miniaturization of the instruments, there was advances in nephroscopy, better stone fragmentation using lasers and lithotripters, and evolution in patient positioning. This is a video showing how a percutaneous nephrolithotomy is basically performed. A percutaneous access is again you under the image guidance. Then, and after securing the tract is dilated. Over this, a sheath is then placed so as to allow a nephroscope to enter. The stone is then either picked up if it is small, or it is broken down into smaller pieces using the energy source, and then a complete clearance can be obtained. Now, coming on to miniaturization. Initially, one can see that the French size is basically the diameter which is being used. It was 24 to 30 French, that of a diameter to 8 to 10 mm was used. And over the years, we have progressed to mini PCNL, then to ultra mini PCNL and micro PCNL. Micro PCNL came into existence in India in 2017 with a French size of 4.85, and a diameter of the hole that is required to gain the access into the kidney is now only 1.6 mm. So one can see how gradually the size of the tract is decreasing, and this is associated with lesser complications. Coming on to advances in nephroscopy, direct nephroscopy was used in early 1960s. Then analog fiber optic nephroscopes came into existence, and now digital camera heads are being used over these nephroscopes so as to get the best vision. Coming on to advances in stone fragmentation, that is lithotripters. In 1995, there was electrohydraulic lithotripter. This is for harder stones. It was inexpensive but less precise. It used to cause more tissue trauma and loud noise. Then came pneumatic lithotripters, which were developed in early 1970s for larger and harder stones, minimal thermal injury. They had caused large fragmentation, and stone retropulsion rates were high. This one can see that how a pneumatic lithotripter is working, and stone extraction at times becomes difficult. Ultrasonic lithotripters were then developed for softer stones. Stone retropulsion was low, good visibility, tissue trauma was less, and the only problem was that it can be used only via a rigid lithotripter, rigid probe. In 1995, the picture changed when the lasers came. Lasers were useful for all stone types. Best visibility and fragmentation was possible. Minimal retropulsion and minimal injury if used with caution and with safety. One can see that stone fragmentation lasers also had their area of progress, from holmium YAG development in 1995 to thulium lasers, and now lasers with Moses technology are being used. This first video is showing fragmentation of the stone. Second, one can see how a popcorning of the stone is done, and the third video showing dusting, how it is being done. One can achieve complete clearance of the stone without any need of any extraction. However, conventional PCNL had what was the need of miniaturization, as there was limitations of conventional PCNL. Conventional PCNL, as discussed, was of size 24 to 30 French. It has a larger tract size, so the risk of bleeding and post-operative pain was significantly higher, and it was a need then which caused the development of smaller size of scopes. Then evolution in patient positioning. Initially, all the procedures of PCNL were being done in standard prone position. Then came our Galdaco modified supine Valdivia position, which enabled us to do supine PCNL. And there was no need to shift the patient or to convert the position from supine to prone. And now total supine PCNLs are also possible, which are not in very regular practice but have been advocated. So one can see how a supine PCNL positioning is done. A patient lies in left lateral. In this picture, he lies in the right lateral position, and how the access is being made with a pillow being placed just beneath, and markings are done so as to get the best access. Coming on to the second part of our armamentarium for stone removal, that is RIRS. RIRS is basically retrograde intrarenal surgery. It is being done with the help of flexible ureteroscopes, flexible optical access. Initially, in the initial part days, had no working channel and no active deflection, but over time there has been development of flexible fiber optic scope. No need of any puncture. The ureteroscope is basically introduced via the urethra, and then using the access sheath, and internally we go via the ureteric orifice into the urethra, into the uterus, and then up till the kidney pelvis. Look, this is how access is gained via the urethra. Inspection is being done inside the ureter, and then once the stone is found in the pelvis, lithotripsy is done with the help of lasers. However, there are also limitations of RIRS. What are these limitations? It is limited effectiveness for larger stones. Stones only up to 1 centimeter or 1.5 centimeters uh, are easily dealt with RIRS. Otherwise, it is a time-taking procedures, and complete clearance at times become difficult. Secondly, because of the high pressure that gets generated, there is risk of ureteral injury and strictures. Why does stricture form? Stricture form because of, as long the procedure is there is going to occur ureteral ischemia, which may lead to ureteral strictures. Then scopes are fragile. Scopes are they are expensive and they are fragile and needs proper training, and it is very important to maintain them properly so that they last long. And lastly, increase in intracranial pressure is responsible for increase in complications like hematoma, like there can be complication of fever, there are bleeding subcapsular hematomas are routinely seen. Coming on to the other approach, that is endoscopic combined intracranial surgery, ECIRS. This is an approach where for usually used for larger stones and to gain and to get complete clearance. Here the puncture is made both via the percutaneous route into the kidney, and retrogradely we also introduce a catheter ureteroscope via the ureter, and then complete clearance can be achieved. Look, this is how percutaneous approach, a percutaneous access is being gained, the stone is being fragmented, and the leftover calculi or any area which are difficult to access via this route can then be dealt with the retrograde route. Advantages of this is improved stone clearance, reduced number of access tracts and relook surgery, and simultaneous management of any ureteral stone if it is present. In this video, one can see how a puncture is being made, and simultaneously a retrograde scope can be seen in the pelvis. Surgical planning is very important. What is to be done, how it is to be done, and which procedure is to be chosen is very, very important. We have stone score and we have Guy's stone score, so as to understand, to see what is to be done. Patient tailored PCNL strategies are to be then decided to decide the choice of tract size, need for stage procedure, or individualized risk estimates. Now, PCNL looks very fancy, it is effective. However, there are multiple complications which are associated with. That is why there is a learning curve which needs to be respected. And I am not trying to frighten you, but yes, PCNL is a deadly procedure. Dreaded complications we have come across. I would like to discuss a few. This is a 35-year-old male who underwent left PCNL elsewhere. On post-operative denial, persistent hematuria was present. There was significant drop in hemoglobin from 14 to 8, and the patient was then referred to our center. On evaluation, DSA, CT angio and DSA, then a pseudoaneurysm was found. thankfully we have a angioembolization facility available at our center. Patient underwent a selective angioembolization of the bleeder, and then we can see that no runoff in the post embolization was found. These complications are more with the size of the tract. Conventional PCNL, we have seen that the incidence of complications was 0.6 to 0.1%, as there was their size is more of the tract, and there are more chances of injury to the vasculature. Another complication is hydropneumothorax, because we are gaining puncture into the kidney, which is just adjacent to the diaphragm and to the pleura. It is very easy for one to injure the pleura, and once a pleura is ruptured, there is development of hydrothorax or pneumothorax or a hydropneumothorax. Similarly, such was seen in a case, a 52-year-old female who underwent left PCNL. She presented with dyspnea on postoperative day 0, and oxygen saturation dropped to 86%. An X-ray was done, which showed, you can see that left-sided whiteout lung, almost the lower lobe collapse is present. The patient was managed with putting up a chest tube. One more complication that was seen recently when a patient was referred to us from outside, a 72-year-old female with thill built. When the puncture was made, the OT notes said that intraoperative detection of colonic injury was there. Patient was managed. How it is managed? How we can leave the tract? We have to make a new tract, and we can leave the tube by putting a colostomy tube over there and let it heal with time, and a new tract has to be made into the pelvic cell system so as to clear the stone. Look, here you can see that the fecal matter is coming out when we are trying to just pull out our access sheath. Now, we have talked about PCNL, we have talked about RIS, and we have talked about ECRS. But what beholds us in future is a few emerging technological frontiers. So I'm going to discuss something about artificial intelligence and machine learning. Artificial intelligence assists us and determine optimal needle trajectory, guided puncture, minimizes complications, identify anatomical structures, analyzes real-time images, and alerts the surgeon, hence improving the safety, and it individualizes risk stratification and procedural planning, and helps in product prediction. We have 3D image reconstruction, which with enhanced visualization, better anatomical clarity, stone complexity mapping, optimized surgical planning to access root precision, and holographic visualization. As one can see in this image, how 3D image reconstruction can help us to access where the artery is, where the veins are, so as to minimize our complications. 3D printing is coming up with wherein CTKUB images are taken, they are put into softwares, and then these are exported to printers, and three-dimensional images of the pelvic cell system can be seen, and one can plan the surgery accordingly, where to make the puncture, how to make the puncture. So this is important. So take home message from my side is that no one size fits all. Every patient is individual, and he needs different types of approach and different surgery so as to get complete stone clearance. Position does matter, but so does precision. Miniaturization is not just a trend, it's a paradigm shift. Miniaturization, yes, is required, but we may have to go back to larger size so as to get complete clearance. Imaging is the most important point, which is initially patient with the help of ultrasounds, X-rays, or with NCCTs, NCCTs, MRIs, and now with 3D printers. They are the game changers. They help us to know where the stone is, what type of stone is, and helps us better planning. Precision embryology is the future, and adaptability is the surgeon's greater asset. So that's it. Thank you very much.
Dr. Sanchit, as of now, we don't have any questions. Thank you, all three of you,
Thank you,
for your talk.
Sanchit sir.
Yes.
Like, so if any questions are there, I will communicate to you by WhatsApp and then we give the answers.
Okay.
So now, they are, whoever is on YouTube connected, if they send any things, we will. So thank you again, all three of you. And this is also, this YouTube live telecast is there in some medical colleges also in
Okay,
general surgery department. If youngsters are interested, for example, plastic surgery, two people want to come, somebody like that, something is there to see your surgeries and things like that, we will communicate. Okay. So
Okay.
thank you again, and three wonderful talks. Okay.
Thank you, sir.
So thank you, everyone. Before we go into the next neurosurgical topic, we have half an hour time. So we will again go in for a video lecture.
इसमें स्टॉप शेयरिंग शेयरिंग कर रहा था. Okay, is the neurosurgery team there? ये वीडियो सारा करता था. Yeah.
Yes.
जरा साथ में रहते हैं वो आएंगे के लिए कैन यू पार्सल वो तो पता है वो उसका नंबर दे दे नहीं तो 2 मिनट में चालू और एक पोस्ट ऑफ आईसी देगा वो कहाँ पे है Thank you, Dr. Sara, for that wonderful demonstration of chemoport. And we are already a little late. Can I request Dr. Ved? Ved is there? Dr. Shreyas? Dr. Shreyas and Ved all have joined. So, welcome to this ASRICon 2025, which is our National Conference of Rural Surgeons. And thank you to Dr. Ved Prakash, who's an additional professor in the Department of Neurosurgery, for this wonderful gesture to teach rural surgeons and young PGs. So over to you, Ved. You introduce your team, then let them give the talk. There are no formal questions because the students are listening through YouTube, actually. So if you want to discuss something at the end, you can discuss. And if anybody has any questions, we will contact you tomorrow through WhatsApp or anything. So over to your team and to Dr. Ved Prakash. Again, thank you to the entire neurosurgical team from SGPJ for this wonderful gesture.
Okay, thank you, Dr. Sabaratnam sir, for this kind introduction. On the behalf of Department of Neurosurgery, SGPGI, first of all, we are very grateful and thankful to Dr. Sabaratnam once again for taking this initiative. And I first of all address the chair, who are the member of office bearers, like Association of Surgeons of Rural India, ASRI. So this is an association where they are trying to teach and provide quality care to each and every person in the society. And the theme of this online teaching is surgery with service for every life everywhere. The theme itself shows that we are dedicated to deliver quality care to each and every person, not only the person who are living in the tier 1 city or tier 2 city in India. So this is the theme which is very pertinent to the current scenario. And once again, on behalf of Department of Neurosurgery, our HOD, Professor Avdesh Kumar Jaiswal, our Chief, Professor Arun Kumar Srivastav, because of some personal commitment, he is not able to log in. He conveys his best regard to Professor Sabaratnam for carrying out this session. And the responsibility which we have been granted to teach basic cranial and spinal anatomy and procedures, which we perform day in and day out to take care of the neurosurgical patients. So just to give an introductory ice-breaking about neurosurgical procedures for the benefit of undergraduate students, we in Department of Neurosurgery, we used to take care of neurological problems right from the birth till geriatric age group. So since birth, the most common inborn congenital anomalies are most common after cardiac anomaly. The neurological problem is split called malformation. That is open neural tube defect. It may be closed also, which undergraduate student might have seen in their wards, swelling or lump over the back, at the lower back, sometimes swelling at the back of the head also. And children with enlarged size of the head, that is called as hydrocephalus, large head having excess amount of CSF in the head, that is hydrocephalus or macrocephaly. And swelling at the back, meningomyelocele, meningocele. And what in a general population, what we come to know, how we come to know about neurosurgical problem. We might have heard that some of our kith and kin, some relatives, they developed brain tumor. So brain tumor is one thing which any civilian, any layman person come to know across, that yes, he is a case of neurosurgical care. And after accident or trauma, maybe multiple modalities, but most common is road traffic accident. They develop some head injury. Or in the day-to-day life, some of our elderly relatives known to some distant relative or our parents also, they come across that somebody is having slip disc or pain in the lower back. So like this, we come across the complaints in our day-to-day life practice where we have to take care of the neurosurgical problems. So over a period of 1 hour which have been granted to us, we will like to cover the major aspect of neurosurgical exposure which will be required for each and every undergraduate student. So we have divided our presentation into 2 parts. One of our faculty member will cover cranial procedures and anatomy of the head, and another faculty member will cover anatomy of the spine and the procedures and classical terms and interventions which are required for spinal problems and conditions. So I would like to introduce our assistant professor, young and dynamic, first assistant professor, Dr. Shreyash Rai, and who will take care of cranial procedures. And second assistant professor is Dr. Mayank Singh, who will take care of spinal procedures and spinal elements. And he will try to be brief and elaborative also, because he will elaborate the terms and conditions which are being encountered by the undergraduate candidates. So I think with this brief introduction, I would like to thank once again the office bearers, the president, the vice president, secretary, of course, Professor Sabaratnam sir, and treasurer of the society. Thank you for this big opportunity to Department of Neurosurgery. Over to you, Dr. Shreyas Rai. Please start your presentation.
Thank you, Dr. Ved. Just let me share my screen. Okay. So I'm Dr. Shreyash Rai, Assistant Professor in the Department of Neurosurgery at SGPJIMS. And I will be taking this talk on neurosurgical procedures, craniotomies, traumatic brain injury, and hydrocephalus. So first of all, introduction. So first we need to understand the basics. What is a craniotomy and a craniectomy? A craniotomy is a procedure in which we remove the bone flap from the skull and place it back after the procedure has been done. Whereas a craniectomy is a procedure in which we remove the bone flap and either discard it or we keep it in the abdominal wall. So they have different role in trauma, tumors, infection, epilepsy, and vascular neurosurgery. For example, in trauma cases, decompressive cranectomy is usually carried out, and the bone flap is either placed in the abdominal wall to be replaced back later on, or it is discarded. So first, before knowing about the craniotomies, we need to understand the basic anatomy. So as we can see here, this is a skull, image of a skull, and we can see that there is the frontal bone, the parietal bone, the occipital bone, and the temporal bone. The pterion can be seen here. Let me choose the okay, frontal bone, parietal bone, occipital bone, and this is the temporal bone. We can see the pterion here. This is the pterion. And what we want to know is that the basic craniotomies are carried out on the convexities are known according to the bone on which they are being carried on. So frontal convexity craniotomy, a parietal convexity craniotomy, or an occipital convexity craniotomy. These are the names based on the bones on which the craniotomy is being carried out. Okay. So before doing a craniotomy, the first thing is positioning of the head and the body. We should remove this and okay, so for positioning of the bone and the body, the head, if needed in a frontal convexity, can be placed in a 0 to 60-degree position, and the body can be placed in supine position. Similarly, parietal convexity would have a head in 90-degree lateral position, and the body can be in lateral recumbent or 45-degree upper body position. Similarly, for the occiput and the suboccipital area, the head can be rotated to 180 degrees and the body can be in the prone or park bench position. And similarly, for a retrosigmoid craniotomy, which is in for vesperoschwannomas, the head will be in 90 degree to 135-degree position and the body will be in park bench or lateral recumbent position. We need to know the difference between the craniotomy and the approach. Craniotomy means the removal of the bone flap, and approach is the intradural portion which is done after removal of the bone flap. So, for example, a supraorbital craniotomy would have a craniotomy just above the eyebrow, and subfrontal approach would mean going below the frontal lobe. Pterional craniotomy and transsylvian approach would have an approach through the sylvian fissure. Similarly, temporobasal craniotomy and subtemporal approach would have a approach below the temporal lobe. And suboccipital lateral craniotomy and supracerebral lateral approach would have an approach lateral to the midline. And median suboccipital craniotomy and telovelar approach would have a approach through the tela choroidea and the velum interpositum, which are structures of the hindbrain. We also need to understand rigid head fixation. After positioning of the body and the head, and after we have decided for the craniotomy, the head needs to be secured. Since we are operating on a microscope, even a small translation of the head would result in major shaking of the head. So we need to fix the head. So for fixing the head, we have two fixation systems which we use commonly at our institute. One is the Sujita 4-point fixation system, which we can see in the first image here, which is attached to the OT table, and the head is placed in the C, and 4 pins are used to fix the head. And similarly, we have a 3-point fixation system known as the Mayfield fixation system, which is the second image here. Here we can see 3 pins which are used to hold the head, and this whole fixation system can be attached to the OT table. Now, since we have decided upon the craniotomy, we have positioned the patient, we have fixed the head on a fixator system. Now we need to know about the craniometric points before doing a craniotomy. So first of all, this is the anterior squamous point, which is on the pterion, which is shown in the first 2 images. The next 2 images shows the asterion. Asterion is an important landmark where the temporomastoid, occipitomastoid, and parietomastoid sutures meet. This is an important landmark for doing a retrosigmoid craniotomy. The last image on the first row shows the bregma, which is the line, which is the point where the coronal suture and the sagittal suture meet. Similarly, inion is the posteriormost prominent point, which is an important landmark for suboccipital craniotomies. Stephanion is a point which is made by the coronal suture joining the anterior temporal line. So these are the craniometric points, and these are useful for doing craniotomies. So now moving on with convexity craniotomies. So first step for a craniotomy would be a skin flap, raising a skin flap. So here we can see a question mark skin flap here, which is a question mark type. The second step would be making burr holes. So burr holes are made based on the bone, and the burr holes are connected to remove the bone flap. So convexity craniotomies have many indications: trauma, tumor, infection, epilepsy surgery. Even in traumatic cases to remove contusions, it is carried out. So they can be frontal, temporal, parietal, or occipital. So these were the basic craniotomies, convexity craniotomies, and now we move on to specialized craniotomies, the supratentorial craniotomies. First is the median frontobasal craniotomy, which is mostly bilateral. Target is medial frontal base and anterior midline. Second is a frontolateral craniotomy, which extends 1 to 3 centimeter lateral to the midline to approximately the sphenoid wing, but does not cross it. The proximal sylvian fissure is exposed intradurally and targets within the sylvian fissure. The anterior skull base and the temporal lobe can be reached. So this here is the frontolateral craniotomy, and supraorbital craniotomy is usually a smaller variant of the frontolateral craniotomy, and it is typically by an eyebrow incision, which limits the size of the craniotomy. It extends 2.5 to 3 centimeter lateral to the midline to approximately the sphenoid ring, but does not cross it, similarly like frontolateral craniotomy. The proximal sylvian fissure is exposed intradurally and targets in the sylvian fissure, skull base, and the temporal lobe can be reached. So here we can see this is the supraorbital craniotomy. Okay, now the pterional craniotomy. Pterional craniotomy extends 1 to 3 centimeter lateral to the midline to the anterior temporal region. So it is centered around the edge of the sutures that form the pterion. The sphenoid wing is always crossed and typically defined as 2/3 of the craniotomy being frontal and 1/3 being temporal. So this is a temporal craniotomy. This is a mini pterional variant, which is a smaller pterional craniotomy. Okay. Then we have the frontotemporal craniotomy, which is usually a large exposure. This here is the frontotemporal craniotomy, centered above the sphenoid wing and sylvian fissure. Okay, and then we have the anterior temporal craniotomy in which the sphenoid wing is crossed. This here is the anterior temporal craniotomy. This is the temporobasal craniotomy in which the exact position varies according to the surgical target, does not cross the sphenoid wing, typically used for subtemporal intradural approaches. These were the supratentorial craniotomies. Now we move on to infratentorial craniotomies. So first, we have the suboccipital median infratransverse sinus craniotomy, which is a midline craniotomy for supracerebral median or paramedian approaches. Example for access to the pineal region or tentorial dural fistula. This is the suboccipital median infratransverse sinus craniotomy. And then we have the suboccipital lateral infratransverse sinus craniotomy. These are craniotomies based on the same principle as the midline craniotomy for an intradural approach along the subdural space parallel to the tentorium. Typically, they are used for supracerebral lateral approaches to the midbrain or other regions. So this is the lateral suboccipital infratransverse sinus craniotomy. And then we have the retrosigmoid craniotomy. This here is the retrosigmoid craniotomy. Typically ranges from the transverse sinus to the base of the posterior fossa along the sigmoid sinus to gain access to the CP angle. CP angle is the region which is reached with this retrosigmoid craniotomy. Then we have the suboccipital median periforaminal craniotomy with opening of the foramen magnum. It is typically bilateral, and there is a mini version also for KRE decompression. This is the suboccipital median for periforaminal craniotomy with opening of the foramen magnum. Then we have a lateral periforaminal craniotomy also, this here. And we have a far lateral variant also, this here. Okay, so these are the craniotomies that we have discussed. Now, moving on to traumatic brain injury. So, traumatic brain injury, the main sources of this lecture are the Brain Trauma Foundation guidelines. So, what is the definition of a traumatic brain injury? It is an insult to the brain, not of degenerative or congenital nature, caused by an external physical force that may produce a diminished or altered state of consciousness, which results in an impairment of cognitive abilities or physical functioning. It can also result in the disturbance of behavioral or emotional functioning. What it means to say is that it is due to an external physical force and is not degenerative or congenital nature. So causes for it: an outside force which impacts the head, causing the brain to move, a direct blow to the head, a rapid acceleration and deacceleration of the head. These are the causes for it. Traumatic brain injury is the leading cause of death for all age groups, contributing to over 60% of trauma-related deaths. The primary goals of management in traumatic brain injury are to minimize cerebral edema, intracranial pressure, and to optimize cerebral perfusion pressure, thereby decreasing the incidence of secondary injury. So traumatic brain injury can be divided into a primary injury and a secondary injury. Primary injury is induced by the mechanical force and occurs at the moment of injury, at the time of impact, at the time of the external physical force which contacts the head, leading to the primary injury. Secondary injury is not mechanically induced. It may be delayed from the moment of impact, and it may superimpose injury on a brain already affected by mechanical injury. So the two mechanisms that cause primary injury are contact, as an object is striking the head or the brain is striking the inside of the skull, or acceleration, deacceleration. Both of these lead to external physical forces, which leads to primary injury. Primary injury due to contact may result in injury to the scalp, fracture to the skull, and surface contusions. Contusions are distinct areas of swollen brain tissue, typically found on the poles of the frontal lobes, the inferior aspects of the frontal lobe, the cortex above and below the operculum of the Sylvian fissures, and the lateral and inferior aspects of the temporal lobes. So these are contusions. Or what other primary injury related hematomas which can occur, we'll discuss later on. Primary injury due to acceleration, deacceleration results from unrestricted movement of the head and leads to shear, tensile, and compressive strains. These forces can cause intracranial hematoma or diffuse axonal injury. So, apart from contusions, what other intracranial hematomas can occur? It is the most common cause of death and clinical deterioration after traumatic brain injury. Hematomas may be epidural hematomas, which are caused by fracture of the temporal bone and rupture of the middle medial artery, where clotted blood collects between the bone and the dura mater. It can grow quickly, creating pressure against the brain tissue. It is an emergency. Subdural hematomas are usually caused by rupture of the bridging veins in the subdural space. They can grow large enough to act as mass lesions, and they are associated with high morbidity and mortality rates. Subarachnoid hematomas are sulcal spaces bleeds, which will we see shortly in the CT head. What is a diffuse axonal injury? Diffuse axonal injury is one of the most common and important pathologic feature of traumatic brain injury. It constitutes mostly microscopic damage, and it is often not visible on the imaging studies. The main mechanical force that causes diffuse axonal injury is rotational acceleration of the brain, resulting in unrestricted head movement. Rotational acceleration produces shearing and tensile forces, and axons can be pulled apart at the microscopic level. Microscopic evaluation of the brain tissue often shows numerous swollen and disconnected axons. Rapid stretching of axons is thought to damage the axonal cytoskeleton and therefore disrupt normal neuron function. So what we mean to say by all of this is that diffuse axonal injury is only microscopic damage, and it is not visible on imaging studies usually. So coming on to imaging, this is a CT head. The bone here is hyperdense, as we can see here. What we see is a biconvex lesion. This here is a biconvex lesion. This biconvex lesion is an EDH, epidural hematoma. So epidural hematomas are biconvex, and they constitute, as we have recently discussed, that it is due to rupture of the middle meningeal artery usually, and these constitute a major emergency in cases of traumatic brain injury. Then moving on to, this is a subdural hematoma. This is a CT head showing a concavo-convex lesion. As we can see here, a concavo-convex lesion. This is a subdural hematoma, which is showing mass effect in the form of midline shift to the opposite side, shifting of the ventricles to the opposite hemisphere. So this is a subdural hematoma. It is also an emergency. Here we can see bleed in the sulcal spaces, Sylvan fissure. There is bleed in the Sylvan fissure, which is suggestive of a subarachnoid bleed. So this CT head here shows subarachnoid bleed here. Now, this here is diffuse axonal injury. As I said, the diffuse axonal injury is not usually visible on the imaging studies, but these pinpoint hemorrhages are suggestive of diffuse axonal injury. These pinpoint hemorrhages are suggestive of diffuse axonal injury. Now moving on to secondary injury. So these were all forms of primary injury: epidural hematoma, subdural hematoma, diffuse axonal injury, contusions. These were all forms of primary injury. Now we move on to secondary injury and traumatic brain injury. It may occur hours or even days after the inciting traumatic event. Injury may result from impairment or local declines in cerebral blood flow after traumatic brain injury as a result of local edema, hemorrhage, or increased ISP. As a result of inadequate perfusion, cellular ion pumps may fail, causing a cascade involving intracellular calcium and sodium, which may contribute to cellular destruction. Excessive release of excitatory amino acids such as glutamate and aspartate exacerbates failure of ion pumps. As the cascade continues, cells die, causing free radical formation, proteolysis, and lipid peroxidation. These factors can ultimately cause neuronal death. So to summarize, secondary brain injury are factors which are not present at the moment of impact, but later on delayed, they can contribute to traumatic brain injury. To summarize, causes of secondary brain injury, these are hypotension, hypoxemia, hypercarbia, hyperthermia, hyperglycemia or hypoglycemia, hyponatremia, seizures, and infection. So these all constitute secondary brain injury and can further exacerbate the primary brain injury. So now we need to, we have understood the primary and secondary injuries. We need to grade the severity of the injury. So head injuries can be classified into mild, moderate, and severe. The Glasgow Coma Scale is the most commonly used system for classifying traumatic brain injury severity. Traumatic brain injury with a GCS of 13 or above is mild, 9 to 12 is moderate, and 8 or below is severe. Other classification systems are also used to help determine severity, duration of post-traumatic amnesia, and loss of consciousness. So this here is the Glasgow Coma Scale. There are three major subfactors in it: eye opening, verbal response, and best motor response. So for eye opening, if it is spontaneous, it is given a score of 4. If the eye opening is to speech, when we are speaking to the patient, then it is given a score of 3. If it is to pain, then it is given a score of 2. And if there is no eye opening, then it is given a score of 1. For verbal response, if the patient is oriented, then it is given a score of 5. If the patient is having a confused conversation, then it is given a score of 4. If the patient only speaks inappropriate words, then it is given a score of 3. And if the patient only shows incomprehensible sounds, then it is given a score of 2. And if there is no verbal response, then it is given a score of 1. Similarly, for best motor response, if the patient is obeying commands, then it is given a score of 6. If the patient localizes to pain, then it is given a score of 5. If there is normal flexion, then it is given a score of 4. If there is abnormal flexion, then it is given a score of 3. And extension is given a score of 2. If there is no motor response at all, it is given a score of 1. So what we can see here, that in each factor, the minimal response that is given is 1. So the GCS, the minimal scoring that can be given is 3, and the maximal scoring is 6 plus 5 plus 4, that is 15. So severity of traumatic brain injury can be graded according to the GCS, in which we have mild, which is 13 to 15, moderate, which is 9 to 12, and severe, which is 3 to 8. Similarly, post-traumatic amnesia can also grade the severity of the traumatic brain injury in cases of mild, which is less than 1 day, moderate, which is 1 to 7 days, and severe, which is more than 7 days. Loss of consciousness can also be used for grading the severity. If the loss of consciousness is for 0 to 30 minutes, then it is mild. 30 minutes to 24 hours, then it is moderate. And more than 24 hours, then it is severe head injury. Now for diagnosis, CT is the most important tool for diagnosis of a head injury. Neurological examination and assigning a GCS score is important. Neuroimaging helps in determining the diagnosis and prognosis and proposed treatment. The preferred radiologic test in the emergency setting is computed tomography. Why? Because it is quick, accurate, and widely available. Follow-up CT scans may be performed later to determine whether the injury has progressed. Similarly, MRI can show more details than CT, as detecting injury characteristics such as diffuse axonal injury. However, MRI is not used in the emergency setting. This you have to remember. CT is quick and widely available, so CT is most commonly used for traumatic brain injuries. X-rays are not used nowadays. Angiography may be used to detect blood vessel pathology or in cases of confusion with aneurysms. Electroencephalography and transcranial Doppler may also be used. So for managing of head injuries, initial evaluation, all patients who presented with suspected traumatic brain injury should undergo a rapid primary and secondary survey with thorough evaluation of their airway, breathing, and circulation. Airway patency and adequate oxygenation and ventilation are paramount to avoiding secondary brain injury. The patient's cervical spine should be immobilized until cervical spine injury is ruled out. Urgent intubation to secure the patient's airway should be considered in any patient who presents with a GCS less than 8, or in those who are unable to protect their airway. So if the GCS is less than 8, you need to consider airway protection and thus mechanical ventilation. IV access should be rapidly established. For monitoring of head injury, it is severely essential in severe traumatic brain injury. It includes ECG, invasive arterial blood pressure, pulse oximetry, central venous pressure, urinary catheter, nasogastric or orogastric tube, frequent neurological examination, temperature, and capnography. In cases of a skull-based fracture, nasogastric tube is not used, since nasogastric tube might go inside the cranium through the skull-based fracture. So a orogastric tube is preferable. For oxygenation and for resuscitation of blood pressure, the guidelines are hypotension or hypoxia. Both must be scrupulously avoided, if possible, or corrected immediately. Hypotension occurred in 35% of patients and was associated with a twofold increase in mortality on a study. The mean arterial pressure should be maintained above 90 mmHg throughout the patient's course. This is the guideline. This is achieved by maintaining mean arterial pressure above 90 mmHg and preventing increases in ICP to be between 20 to 25 mmHg. So here we know that cerebral perfusion pressure is equal to mean arterial pressure minus the intracranial pressure. Now cerebral perfusion pressure should be maintained at a minimum of 70 mmHg. So mean arterial pressure should be above 90 mmHg and intracranial pressure should be about 20 mmHg. Then only the cerebral perfusion pressure can be maintained at a minimum of 70 mmHg. The first priority for the head injury patient is complete and rapid physiological resuscitation. No specific treatment should be directed at intracranial hypertension in the absence of signs of transintural herniation or progressive neurological deterioration not attributable to extracranial explanation. So the first priority always is complete and rapid physiological resuscitation. Now, monitoring of the patient can be done by CT scan, which could be done on admission and repeated whenever there is change in symptoms or signs. Frequent neurological examination is essential. Early recording of GCS, early recording of pupil size and reaction, monitoring ICP if available. Mannitol induces change in the blood rheology and increases cardiac output, leading to improved cerebral perfusion pressure and cerebral oxygenation. Improvements in cerebral oxygenation induce cerebral artery vasoconstriction and subsequent reduction in cerebral blood volume and ICP. So this is how mannitol acts. Osmotherapy is, this is how mannitol acts. Mannitol is used for osmotherapy, and since there is improvement in cerebral oxygenation, which leads to cerebral artery vasoconstriction and subsequent reduction in cerebral blood volume, which finally leads to decrease in intracranial pressure. Mild dehydration after osmotherapy is desirable and may improve cerebral edema. Also, it decreases CSF production by up to 50% and leads to prolonged ICP decrease. So guideline mannitol is effective for control of raised intracranial pressure after severe head injury, no doubt in that. Effective doses range from 0.25 to 1 gram per kg body weight. Now about mechanical ventilation. In traumatic brain injury patients, hypoxia, hypocarbia should be avoided. PaO2 should be above 100 mmHg and SpO2 above 95%. Mechanical ventilation should be started at GCS 8. If there is 8 or less than 8 GCS, mechanical ventilation should be done. PaCO2 in first 24 hours should be 34 to 38 mmHg, and mild hyperventilation can be started for PaCO2 to be 32 to 35 mmHg in case of increased intracranial pressure. And end-tidal CO2 is to be monitored and perform blood gases every 15 to 20 minutes after any change in ventilatory parameters. Surgical intervention whenever decided by a neurosurgeon to decrease intracranial hypertension. These surgical interventions are performed on mass lesions or to eliminate objects that penetrated the brain. Mass lesions are like contusions or hematomas, causing significant shift of intracranial structures. So, this is how the management of a traumatic brain injury is done. First of all, initial resuscitation is the most important portion. Guidelines for managing the mechanical ventilation, hypotension, cerebral perfusion pressure, and cerebral blood flow is important. And lastly, surgical intervention wherever needed in cases of mass lesions or to eliminate objects that penetrated the brain. Now moving on to the third portion of the lecture, which is hydrocephalus. The term hydrocephalus is derived from Greek words hydro, meaning water, and cephalus, meaning head. As the name implies, it is a condition in which the primary characteristic is excessive accumulation of fluid in the brain. Hydrocephalus is the abnormal accumulation of CSF in the ventricles and cavities of brain. This causes increased intracranial pressure inside the skull and may cause progressive enlargement of the head. It is found in 1 to 3 of every 1,000 born children worldwide. So moving on to some basic anatomy of the CSF. Normal amount of CSF is about 150 ml. CSF formed by choroid plexus and is absorbed by arachnoid villi. And normally about 500 ml of CSF is formed every day and an equal amount is absorbed. So normal CSF circulation pathway, we need to remember this. The lateral ventricle is the place where the CSF is formed from the choroid plexus, and through the foramen of Monro it goes into the third ventricle. Through the aqueduct of Sylvius it goes from the third ventricle to the fourth ventricle, and from the fourth ventricle through foramen of Magendie it goes into the central canal of spinal cord, and through the foramen of Luschka it goes into the subarachnoid space. It is reabsorbed in venous sinuses by arachnoid villi. So this is a normal CSF cycle. And about 500 ml of CSF is formed every day and reabsorbed every day. Hydrocephalus can be communicating or non-communicating. Communicating hydrocephalus is a condition that results when the arachnoid villi are unable to adequately reabsorb CSF. Intraventricular or subarachnoid hemorrhage is present. Infectious processes such as meningitis may also render the arachnoid villi to be non-functional. May also be due to overproduction of CSF. This is rare and is usually associated with a choroid plexus papilloma or a choroid plexus carcinoma. Non-communicating hydrocephalus is a condition in which the ventricular system does not communicate with the arachnoid villi due to some obstruction in the normal pathways of CSF flow. So there is normal flow and something is obstructing the flow, which leads to non-communicating hydrocephalus. Consequently, CSF is produced in the ventricular system but cannot flow to the arachnoid villi to be reabsorbed. Such obstruction can occur when pathways are blocked by a tumor, congenital abnormalities of the brain, cysts, inflammation from infection, or any other condition that interferes with the patency of these pathways. So etiology of hydrocephalus. So first of all, the congenital etiologies, intrauterine infections, mainly in rubella, toxoplasmosis, and cytomegalovirus. These infections lead to hydrocephalus. Congenital brain tumor, intracranial hemorrhage, congenital malformation, malformations of arachnoid villi. These are the congenital causes of hydrocephalus. Now moving on to acquired causes of hydrocephalus, which are inflammation, trauma, neoplasm, space-occupying lesions like tuberculoma, subdural hematoma, abscess, gliomas, ependymoma, astrocytoma, pseudotumor cerebri, hypervitaminosis A. Connective tissue disorders like Hurler syndrome and achondroplasia can also cause hydrocephalus. Degenerative atrophy of brain, AV malformations, ruptured aneurysm leading to subarachnoid hemorrhage can also cause hydrocephalus. Cavernous sinus thrombosis. So this is a clinical picture of a kid with hydrocephalus in which we can see that he has an enlarged head. So clinical manifestations usually result in an unusually large head, a rapid increase in the size of the head, a bulging or tense soft fontanelle on the top of the head, Mackey-1 sign or cracked pot sign, in which when we percuss on the head, a cracked pot-like sound occurs. Eyes is fixed downward, which is known as sun setting of the eyes, and shiny scalp with prominent scalp vein. Poor feeding, seizures, deficits in muscle tone and strength, responsiveness to touch and expected growth, vomiting, sleepiness, irritability are other factors which can occur. So for diagnostic evaluation, what can be done? First of all, is the most important thing is physical examination, positive transillumination of infant head. As I told, typical crackpot sign, Mackey-1 sign of the skull bone. Ophthalmoscopy. How will ophthalmoscopy help? Ophthalmoscopy will show the fundus of the patient and it will reveal papilledema. A primary papilledema will result in suggestive or will suggest that the patient has hydrocephalus. MRI, CT, cranial ultrasonography, and X-ray skull as and when required are needed for diagnosis. So for medical management of hydrocephalus is directed towards reducing intracranial pressure, prevention and management of complication, and managing problems caused by the pathology. Medical management includes the use of osmotic diuretics and loop diuretics to reduce CSF production. Medical management is temporary relief, but main management is surgery. So this you will have to remember. Acetazolamide is used for medical management, but it is temporary only. The main management is surgery. Surgery is done by a shunt. A shunt is made up of a radio-opaque plastic and has ventricular catheter, pressure valve, pumping chamber, and distal catheter that directs the flow of CSF from the ventricles to the other areas of the body from where it is absorbed. So, what options do we have in surgery? One is a shunt, ventriculoperitoneal shunt, which we have all heard about. It is placed in the ventricles. One end is in the ventricle and the other end is in the peritoneum. And the CSF goes from the ventricles to the peritoneum so that the hydrocephalus can be resolved. Other options are endoscopic third ventriculostomy, which are done in cases of aqueductal stenosis. Other shunts that are used are ventriculoatrial shunts, ventriculopleural shunts. Ventricular shunts are not used nowadays. Choroid plexectomy is also a procedure which can be done to reduce the CSF production. So prognosis depends on early diagnosis and prompt therapy. With improved diagnostic and management techniques, the prognosis is becoming considerably better. Approximately 2/3 of patients will die at an early age if they do not receive surgical treatment. So surgical treatment is paramount, and most important is the ventriculoperitoneal shunt. Thank you. Now, I would like to call.
Thank you, Dr. Shreyas. Thank you, Dr. Shreyas, for giving a very elaborate description about the neuroanatomy of skull, type of craniotomies, and brain trauma foundation about head injury. Brain trauma foundation is like our constitution in neurosurgery in case of neurotrauma. So you have very well covered each and every aspects, right from the diagnosis, treatment, up to prognosis, and at the end, hydrocephalus, which almost each and every undergraduate student come across once they visit the surgical ward. So with this, we conclude the first part of our lecture. Thank you, Dr. Shreyas, once again. Now, I would like to invite Dr. Mayank. Dr. Mayank Singh is assistant professor and he will be focusing on spine, neuroanatomy of the spine, as well as pathologies associated with spine. Over to you, Dr. Mayank Singh.
Thank you, sir, for letting me speak here. Sir, first, I would like to share my screen. Share.
It's sharing, Mayank. It will take some time.
Is my screen visible?
Yeah, visible.
Okay. Sir, as mentioned by you that I will be covering some special, some common spinal topics which will be, which a general surgeon must know in his practice. Okay, this is the spine. As you can see, this is the cervical spine, thoracic spine, lumbar spine, sacrum, and the end one is coccyx. So these are the normal curves which we have already studied. We have seen in many of the radiologies. So this is the basic anatomy, basic curves of the spine. Now, this is the spinal motion segment unit. It is the functional unit of spine. So this is which consists of two spinal vertebra, one disc, and the joints. So this is the motion segment. If we cut this segment from the midline, then we can see that this is the vertebral body. This is the second one, and intervening between those two is the intervertebral disc, and this is the end plate we can see. And there's the spinous process. This is the foramen for exiting nerve root. As we can see here also, the nerve is exiting from this foramen. This is the joint between the two vertebrae, and this is yellow colored showing the ligamentum flavum. These are the ligaments which are present in between the vertebrae. Now, in the next, we can see this is the axial section of the vertebra. This is the vertebral foramen from which the spinal cord runs downwards. And this is the transverse process, spinous process, lamina, and this is the articular facet. So, and this is the body. In this, we can see that there is the degenerative changes, and these are the osteophytes which becomes obvious in the advancing age, and overuse of the spine in young also. So this is the sacrum. We can see that there is a sagittal image. This is the spinal cord, and the distal end of the spinal cord, this is the conus medullaris, and these are the various nerves which are being exited from here. This in the lower part forms the horse tail like structure. Therefore, it's also called cauda equina. This is the section of a spinal cord. This is the anterior part. This is posterior. The tracts which are shown on the left side constitutes the descending tracts, which are also known as motor tracts. And this is the sensory tracts which are being shown in the pink. These are present on both the sides, but it is shown in this figure in the right and left. So most importantly for us to remember is that this is the corticospinal tract. This constitutes the tracts from the cervical, thoracic, and sacral region, which is the main motor tract in the spinal cord. This pink one is the spinothalamic tract, which is the main sensory tract, which through which the pain and temperature fiber travels. And posterior, we can see that this is the posterior column through which the position and vibration sensation travels. So, and in this also we can see that this is the gray matter, which is S-shaped, and peripheral is the white matter. These are the spinal roots of which we should keep in mind while examining the patient. For every root, we have one or two or many supplying muscles. This is the function of the muscles. This is the sensory dermatome, and some of the roots have their reflexes. So by this, in examination, we can know the level at which the spinal cord is injured or root is involved. So as we can see that in the C5, biceps jerk is involved. Suppose a patient is having diminished triceps jerk, then we can just know that the C7 most probably be involved in that. In this, we can see that these are the further down, we can see all the nerve roots. The L4, L5, S1 forms the epiconus. So in the epiconus and conus, these are, as I've already told, that conus is the distalmost part. Suppose if a pathology occurs in conus, then S2 to S5 region will be involved. So in this, the bowel and bladder incontinence occurs. So suppose a patient comes with any pathology and says that he is having perineal sensations diminished, or bowel bladder involvement, and rest of the means power is intact, so we can suspect a lesion to be at the conus. Similarly, epiconus lesion can have suppose a patient is having foot drop, or he is having means on examination he is having Achilles jerk is diminished, then we can see that it is the S1 dermatome root which is involved. And suppose, which earlier I have mentioned, that cauda contains many of the nerves. So it contains L2 to C1, that is coccygeal nerve. So in cauda syndrome, all the nerves from L2 to C1 is involved. So these are some of the very emergent condition for which the patient is asked to visit a neurosurgeon for required management. This is the picture we can see. As already I said that the various radicals have specific dermatomes for that. So in practice, many of the patient comes to us with tingling sensation in this greater thumb or this middle finger or this small finger. So we can see that this is the thumb is supplied by the C6 nerve, middle finger is C7, and this little finger, little toe is S1. So these are some of the very common conditions which we encounter in our OPDs. So regarding the trauma of the spinal cord, the injury can be complete or incomplete. In the complete, there is no motor, no sensory, no reflexes present. Incomplete, we can no motor, only sensory is present. Type C is 50% of the muscle has grade less than 3. That is the MRC grading. That is the grading of power. And in type D is grade more than grade 3 power is present, and 3 is normal. So we need to classify the injury on basis of these ACR impairment scale. In the complete spinal cord injury, we get the following conditions like spinal shock and neurogenic shock. So we need to differentiate between the two. In spinal shock, motor, sensory, reflexes, and autonomic all are involved below the lesion. Whereas in the neurogenic shock, hemodynamic collapse is due to because of sympathetic tone. Otherwise, motor and sensory may be normal in this case. This is the common type of incomplete injury. This is the Brown-Sequard syndrome, is the hemisection of the cord. So in this, the same side of motor is gone and other side of sensory. This is the central cord syndrome, in which the motor loss is more prominent than sensory loss. This is the posterior spinal cord syndrome, in which the posterior columns are more involved. That is pressure and vibrations, position sense and vibration. And there is the anterior, in which the motor is involved mainly, and sensory also involved below that level, because cortical spinal tract and spinal thalamic tract are involved in anterior spinal cord syndrome. So this is one of the main thing we should remember in this case. Suppose if a patient comes to our setup, and if he is showing any neurological deficit like decrease in power and with a history of trauma, so it is better to start a methylprednisolone with this mentioned dose. Although there have been very controversial discussions, various studies have been conducted in this, but in our institute we follow that if the injury is less than 24 hours and more if it is less than 8 hours, then we give 30 milligrams. This is the this bolus dose. Then we continue with the maintenance dose for 24 hours. So it is better to give that unless there is any absolute contraindication for that, like sepsis. Suppose you have a patient in your setup. So this is the main thing which we need to do, is the primary resuscitation. Along with that, spine board, the patient should be stabilized over the spine board with head stabilized. This is the most important step we should remember, because during this stage, many of the patients suffer major injury and irreversible injury too. Now, after that, we can reset the patient. We can transfer the patient to the center where a doctor can examine the patient. So this is the format which we should follow while examining the patient of a spine injury, or we don't know that whether the patient is having spine injury or not. We keep in our mind that this patient might be having spine injury unless it is proven, unless it is ruled out. So this is the three people are sitting, rolling here. One staff is at the head side and one is examining. This is the basic anatomy. This is the bit detailed anatomy, but we can see that there is a C1, this anterior arch, posterior arch, there's a lateral mass, there's the C2, C2 vertebra, which is having the dens, this body, this is the lamina, this is the pedicle, this is the foramen for vertebral artery. These are some of the ligaments. This is the most important ligament which stabilizes the C1 and C2 joint. Now, one criteria is nexus criteria, which suppose a patient comes, when should you go for radiology, X-ray or CT scan? So when the patient is having focal neurology deficit, midline spinal tenderness, alter level consciousness, intoxication or distraction injury. In these cases, we should go for X-ray of the cervical spine to rule out any injury in this case. These are some of the points by which we can diagnose if there is any pathology present due to trauma or not. Now, these are, we should keep in mind, these are the 4 lines. There is the anterior margin line, posterior margin line, spinolaminar line, and there is the posterior spine lines. And this we can see, this should be in a continuous manner. Any disarrangement of this might suspect a injury in the patient. So occipital condyle fracture, these are three types of fracture type. One is stable, type 2 is avulsion fracture, which is also stable. Type 3 is avulsion fracture, which requires fixation, that is major surgery in this case. There is the atlantoaxial dislocation. It can be anterior, posterior or rotatory. This is the anterior arch of the C1. This is the dens. We can see this is the distance increase in this case. So we can suspect atlantoaxial dislocation. So in these cases, the head should be stabilized unless the main intervention has been done. C1 fracture, we can see that this is the Jefferson's fracture. Anterior arch and posterior arch is having burst fracture. There is a lateral mass fracture, anterior fracture, posterior arch fracture. In this, we can see a CT scan showing the anterior and posterior fracture in this case. So these patients must be stabilized before any fixation surgery. This is the C2 vertebra. This is the type 1 fracture, that is tip of odontoid process. This is the base of odontoid process. This is the body of the C2 vertebra. So these have various different presentations. Suppose we get the CT in our clinic showing this, so we can suspect that this is C2. This hole is C2. This is odontoid, and this is fracture at the base of the odontoid. So it is type 2 odontoid fracture. So it needs surgery. This is the anterior stretches of the C2 over C3, which is also known as hangman fracture. So whenever we see and scan showing a vertebra that had been shifted to in anterior side, so we can suspect that this is hangman fracture. There is the subaxial spine, means from C2 to C7 whenever there is injury. It is the AO classification which we follow. But the important thing is we should remember is that if we have the scan, we see the patency of this canal, and clearly we can see that there is something wrong here. This alignment is disrupted. Something is coming. This is the disc material. This is the disc. How we count? This is the 2, C3, C4, C5. So C5 and C6, C5 is slipped anterior to the C6. So this is the disc, C5, C6 disc, which is compressing. Cord is showing changes. See, this is white matter. Cord is showing changes. This patient might be having motor or sensory loss. So this patient requires surgery. But important thing we should remember is that the head should be stabilized when we receive the patient and while doing primary and secondary resuscitation. Here also we can see that this is the C5 fracture, burst fracture. This has been, the spinal canal has been compromised. Here also this anterior says the spine canal has been compromised and pressure is over the spinal cord. Here we can see that the vertebral body has been fractured and the fracture segment is in the spinal canal. So it is also a candidate for surgery. So this is the lumbar spine vertebra. This is showing the anatomy. This is showing that is the spinal motion segment. This from L1 to L5. This is the foramen from which the nerve comes out. We have this three column theory in this. This is the anterior column, middle column, and the posterior column. Anterior column consists of the half of the anterior vertebra. Then this is the intervertebral disc. Posterior half of the body and intervertebral disc considered middle, and the rest posterior considered posterior column. So any of the two columns, if fractured, or two or more than then the spine becomes unstable. It needs surgery. It needs fixation. This is the Telix score, which according to which we calculate the scoring, and if the scoring is greater than 5, then the patient is potential candidate for surgery. Here we can see that this is I think it's the D11 vertebra that is fractured. No, this is the D12 or L1 fracture, and this is compromising the spinal canal, and there is compression over the this canal, needs surgery. Here also we can see that this is a compression fracture. Here we can see that there is compression fracture, although there is not much canal compromise, but clinically we should see the patient whether he is having with what ASRI type of injury. This is the condition known as prolapse intervertebral disc, which we generally found in our OPDs. Patient complains of this radiculopathy, tingling sensation, numbness, and sort of pain, and lower back ache, which is radiating to any of the limb. So the pathology might, one of the cause might be this intervertebral disc. This is the L5 and this is L4. So this disc is being protruded in the spinal. This is the canal. So this disc is being protruded. Here we can see there is the axial section. This is the disc which is getting protruded in the canal. So it is compressing the nerve which is exiting. So one of the major complaint patients is that he has L5 radiculopathy that needs conservative management. Initially 90% of the patient improve with the conservative management, but some patient require surgery also. This is the spondylolisthesis. In this we can see that this can be either traumatic or pathological. Their L5 is shifted anteriorly over the S1. Here we can see, and there is the pseudo disc which we can see. So there is a compromise of the canal and the vertebral and the spinal foramen through which the nerve passes. So the patient typically has complaint of neogenic claudication, in which the patient walks to some distance and then he complains heaviness of both whiter thighs and pain increased. So this is also the candidate for surgery. Initially we try conservative management, but if it fails, then we go for surgery. This is how we grade the listhesis. There is the grade 1 and more anterior is grade 2, grade 3, grade 4, and grade 5 when this vertebra comes just anterior to that. So it is known as spondyloptosis. Here we can see that this is a spondyloptosis. It has slipped from this vertebra completely. This seems to be grade 2 type of listhesis. So this patient needs surgery. Okay, thank you.
Thank you, Dr. Mayank, for providing a very elaborate description of spinal anatomy as well as description of majority of the components of spine trauma. I must emphasize that you have covered the spectrum of advanced trauma life support as well, where A, B, C, D, E is taken care, and along with that, the classification of spine injury like ASIA, American Spinal Injury Association, ASIA grading is mandatory, which is followed worldwide. And along with that, you have covered the all types of spinal injury and management also. Thank you very much for your nice lecture on spine and spinal trauma. I think with this, we conclude the neurosurgical portion for general surgery candidates. Over to you, Professor Sabaratnam, sir.
Thank you, Ved, Shreyas, and Mayank. Thank you so much. We are very indebted from rural surgeons. And thank you again to the entire fraternity of neurosurgery department. And if any questions, we'll get back to you. So thank you again. Have a good day. And tomorrow we meet with the endocrine surgery session. Thank you again. Okay, bye.
Thank you so much, sir. Thank you.